Solution. I will just have a speaker. Okay. Very good morning and welcome to all online vocational training on advancements in physiological function tests in domestic animals and pets. Friends, today we have two eminent speakers with us. First one is Dr. Nainan Jacob. He is professor and head Department of Veterinary Physiology, RIVR Puducherry since 2016. He has done his BBSc and MBSc from College of Veterinary Science and A.H, SK Nagar, Sardar Kursi Nagar, and PhD Animal Physiology from College of Veterinary Science and A.H, Anand Agricultural University, Anand. His PhD research work was on Gir, cattle, and Jaffrabadi buffaloes from CBF, Junagadh, Agricultural University, Junagadh. He has got the Vice Chancellor Gold Medal for Best Graduating Students in Gujarat Agricultural University. He has published 62 number of the research papers, 4 review articles and 2 popular articles, 12 international publications. He has published 3 books and 1 chapter in book. He has got a very vast experience of 25 years in veterinary services. His initial career was at LRS and LITC at the SK Nagar GAU, erstwhile GAU. Now it is been partitioned into the Sardar Kursi Nagar SDIU as well as AAU and JAU. Now, then after he moved to the Rajiv Gandhi Veterinary College of Animal Science, that is the RIVR in Puducherry. His main area of interest is hematology, endocrinology, and environmental physiology. With this brief introduction, I welcome you, sir, and I invite you to deliver your lecture on hematological functional test and its advancements in veterinary sciences. Welcome, sir.
Thank you, doctor. Can you hear me? Are you able to hear me?
Yes, yes. You are audible, sir.
Sir, before start the lecture, I want to introduce our eminent chair, Dr. M.D. Odeda. He is Associate Professor and Head in the Department of Livestock Production Management. He is acting as Chairman of this session. Then next to Dr. Odeda is Dr. S.S. Sindhi. He is Associate Professor and Head in the Department of Public Health in Veterinary College, Junagadh. And today's session reporter is Dr. Bhavika Patel. She is Assistant Professor in Department of Veterinary Medicine. With that, I welcome all the esteemed speakers as well as the online participants. Please, sir.
Yeah, thanks a lot. Thank you very much. Can I start my lecture or should I wait for some more?
No, sir.
Yeah.
Many.
Thank you. Thanks to the chair and to the co-chair and to the rapporteur and definitely the organizing secretary and also the organizing secretary, Dr. Arun, and our beloved Dean, Dr. Tang sir, and also to the Vice Chancellor and all of you for giving me this wonderful opportunity to be speaking to you. It is indeed, I feel very elated to be sharing some of my slides with you and to be talking on this. Initially itself, but I would like to say that I am going to speak only mainly targeting the UG students in mind. So my topic would be mainly the basics that are concerned with hematology before I start sharing my slides here. And there may be some things that I have put in which may interest PG students and the general audience at large. So I thank all of you for being here. I thank all the participants also on the Zoom and other platforms who are here for being here and if you join here. Okay, thank you very much. Can I start sharing my slide?
Please.
Is my slide visible?
Yes.
Okay. Okay, is it full screen now? Can you hear me, all of you?
Now
Is it full screen?
Yes, yes.
Yes,
Now
sir.
it's full screen.
Yeah, thank you very much. So I shall now go on into our lecture, okay, without wasting much time. So today's lecture or today's talk or today's sharing of information and discussion, I would rather say, is about hematological functional tests and their advancements in veterinary sciences. Okay, and I come to the first slide. See, what is the importance of hematology? Why do we do hematology? Whenever you go to an hospital, any clinician, any place, any test that you do, the basic thing that they ask you first is to do a blood test. So all hematologic function tests are very essential. And as a veterinary student and as a veterinary graduate and postgraduate and as a clinician, it is very, very important for us to know all the methods and all the different types that we methods concerned with the enumeration of different functions of the blood cells. Okay, so the hematology function test actually include all the tests on all the blood, and also the blood producing organ. Okay, so the importance is very, very well known to all of you. But the main thing about hematology is it depends on a number of factors, such as the age, the sex of the animal, the climate, the weather, whether the animal is under stress. It may be physiological stress, it may be pathological stress, it may be seasonal stress. It depends on the season. It depends upon the physiological state of which the animal is in, whether it's a growing animal, whether it's a lactating animal, whether it is a pregnant animal, whether it's a dry animal. Okay. So it is very challenging, especially to the veterinarians, especially in view, because we have a number of species, and within each species, we have a number of breeds. So we need to remember the normal values of all the species and all the breeds that we have. Okay, it's not possible to remember all the breeds. So basically, we need to know about all the species that we have. In the course of the lecture, we'll be looking into that, and I'll be stressing on some things that you should remember as we go ahead. Okay. So is it important to do this test? That's the first question. Yes, it is. Why? Because they need to determine and screen the animal's general health status. First thing. Second thing, whenever you go to an hospital, they say do a CBC. What is a CBC? A CBC is a complete blood count. Why do you need to do a complete blood count? Because it leads to diagnosis and monitoring. Monitoring of what? Of your normal health or of any variety of diseases that may affect your blood cell. So why should the animals be tested? Okay, sorry, not why. When should the animals be tested? So it is recommended that just like humans, we have a routine hematology checkup, even animals should be routinely screened for hematological parameters, especially when it has got any disease and it is suffering from some signs and symptoms that may be related to any condition with effect to the blood cell. Secondly, when we are treating the animals, to monitor the progress of any treatment, we need to do a hematological test. So what is it that we are going to test for? What are the cells that we are going to test for? Let us say we all know that in the blood there are three cells. One is the RBC, the WBC, and the platelet. So for the RBC, we need to first do the enumeration of RBCs, the hemoglobin and hematocrit estimation, the ESR determination. We can calculate based on the RBC, hemoglobin, and PCV. We can calculate the mean corpuscular volume. We can calculate the mean corpuscular hemoglobin. We can calculate the mean corpuscular hemoglobin concentration. We can measure the red cell distribution width. This is normally done with an autoanalyzer. And we can also do the reticulocyte count. The second is the white blood cell. What are the tests we do for the white blood cell? Enumeration of WBC, that is what we call as TLC, total leukocyte count. We can do a differential leukocyte count. In literature, many places you will find it as WBC differential. You can identify the cell and nucleus shape and size. That is, you can stain a blood smear, and you can find out the neutrophils, the lymphocytes, the eosinophils, the monocytes, and the basophils, which are the different type of WBCs. And after doing all this, you can determine the absolute leukocyte count, which is important. Because the absolute leukocyte count gives a correct picture of whether there's an increase or whether there's a decrease in the cells. What are the tests for platelets? You can do a total platelet count. That's a enumeration of platelets. But nowadays, since we have an autoanalyzer, the main platelet volume is also being determined, and also the platelet distribution width is being determined. We'll discuss in detail how these factors affect, or what happens when there's an increase or decrease in each of these factors, which is what is going to be our next part of our lecture. Okay. So basically, what does a CBC help you to do? Okay. A CBC can help you diagnose various conditions like anemia. Anemia may be due to various causes. You can diagnose bone marrow disorders, hemoglobin abnormalities, thalassemia, sickle cell disease, even dehydration. You can also diagnose infections, inflammation, leukemia, lymphoma, myeloproliferative neoplasms, and myelodysplastic syndromes. So I know these are big bombastic terms for a UG student. Myelo means bone marrow. Proliferative neoplasm means a tumor due to which the bone marrow proliferates and there is more of blood cells. Myelo again is bone marrow. Dysplastic is where there's a dysfunction of the bone marrow. Okay. So we talk about the bone marrow cancer and especially about nutritional deficiencies, that is iron, vitamin B12 and folate, and also about the platelets, and it will also help you diagnose an autoimmune disease. So this is how Dr. Arun sir is taking a hematology. He must have told you this is how the blood cells are normally formed. Okay, there's a picture I've taken from the internet. Okay, so the pluripotent stem cell, there's a pluripotent stem cell, pluripotent, a stem cell which has got the potency to become plural cells, many cells. These plural cells, okay, they divide mainly into the myeloid stem cell and in the lymphoid stem cell. The lymphoid stem cells produces CFU, that is colony forming units. Colony forming unit E forms the reticulocyte. Colony forming U mega karyoblast, which forms the megakaryocyte, from which it breaks down and forms platelets. The CFU GM, that is a granulocytes and monocyte. So it forms monocyte and neutrophil, eosinophil, and basophils. And then you have the lymphoid stem cell, from which you have a pre-B cell, which is you form the beta lymphocyte, sorry, the B lymphocyte, and the thrombocyte, that's a T lymphocyte, that is, and you have plasma cells, which are formed from the B lymphocyte. Okay. Now, see, normally when you look into the blood picture, the B lymphocytes are large, which you call as a large lymphocyte. And T lymphocytes are the small lymphocyte, which you call as a small lymphocyte. Okay. So I'll give you a mnemonic for you to remember easily. Remember, B means big. B stands for big. So they are large. T stands for tiny. So they are small. Okay. So let us see directly going to the RBC analysis of the RBC. Okay. What happens, okay, when there is an increased RBC count and the other parameters related to RBC. Okay. So before that, we should know what is an RBC. I've just put some pictures over here. Okay. One is RBC in bovines. Okay. Other is an RBC in canines. You can see that there's a central pallor. Okay. That there is a slight dimness in the center because the RBCs are biconcave in shape. But again, you can see that the shape of a bovine cell is lesser than that of a canine cell. Okay. And then I'm showing you goat cells, goat RBCs, which are much, much lesser. I'll be telling you, or I'll be showing you, okay, I'll be showing you the sizes at a later rate. Okay. Then we talk about the RBC in a camel. Okay. See, the RBC in a camel is elliptical and is biconvex. Okay. Here we said it is biconcave. Okay. And the RBC in an avians. Avians RBCs are again biconvex and they are, excuse me. Okay, avian RBCs are biconcave and they are nucleated. Okay, for a UG student, this is important. You should know this. Okay. So what is the advantage of an RBC being a double concave or a biconcave, which is called as the discocyte. Okay. See, this helps in more effective gas exchange, and it will help the RBCs to pass through narrow blood vessels, okay, by turning on themselves without breaking. Okay, so there are various shapes of RBCs in different animals, which we can see now. Okay, now see, in horses, there's a Rolex formation which will happen. The RBCs will join together, like you keep one coin on the top of other coin, or one saucer. When you go to a hotel, you can see a number of saucers that are arranged one on the top of the other. Okay, so here you can see, here this is an actual blood picture, this is an illustrative picture, this is an actual picture. You can see the blood cells joining together to each other, the RBCs. Because of this, what happens? The weight of the RBC increases, and so they settle down very fast. So when you talk about the erythrocyte sedimentation rate, the Rolex formation in a horse will help it to increase the sedimentation rate. Okay. Then at the same time, you must have studied about sickle cells. Okay. See, what is a sickle cell? There's a sickle cell. It looks like a sickle. Okay. It looks like a sickle that you use to cut the grass. Okay. Why does it look like a sickle? Because, okay, the round shape of the RBC is lost. Okay. And at the position number 6 in the beta chain, valine replaces the amino acid valine replaces glutamate. Okay, that is how you get a sickle shape. Okay, so we come to RBCs. The unit of measuring RBC is in 10 raised to 6 per microliter. Okay, if you are expressing in liters, it becomes 10 raised to 12. Okay, so what happens when there's a decrease in our RBC, or what will be the conditions? Okay, or when it decreases? One is when there is anemia. Second, when there is chronic bleeding. Again, there is any hemolytic anemia due to which RBC destruction occurs. We talked about nutritional deficiencies, iron deficiency, vitamin B12 deficiency, and folate deficiency, bone marrow disorders, chronic inflammatory diseases, and chronic kidney disease. Okay, why chronic kidney disease? Kidney is responsible for the production of erythropoietin. Okay, please remember that. And erythropoietin is what is responsible for erythropoiesis, formation of RBC. So any kidney disease will again affect the RBC count. Okay. When does an increase occur? An increase occurs is when increase in RBC is called as polycythemia. Decrease is called as anemia. And increase is called as polycythemia. Okay. When there is dehydration. Okay. When there is any lung or pulmonary disease. When there is any kidney tumor that will produce excess erythropoietin. Okay, in humans, it has been seen that smoking causes polycythemia. Okay, physiological polycythemia is caused when you are at a high altitude, when you are at a very high altitude. Okay, then there's genetic causes, altered oxygen sensing, and abnormality in hemoglobin oxygen release. And of course, polycythemia vera. Okay, polycythemia vera is a rare disease of the bone marrow. Okay, in which the number of blood RBCs increase, and the number increases so much that the blood flow is affected and it plugs the arteries, especially the small capillaries, and the blood cannot flow easily. Okay, it is also called as a primary polycythemia. Okay, so I'm just giving you a picture. Okay, how to distinguish between an anemia and polycythemia. See, this is the picture here over here. Shows you a normal blood count, okay, with a hematocrit, a buffy coat, and the plasma. So in anemia, the RBCs decrease, so the hematocrit decreases over here. The PCV, the packed cell volume decreases, okay. And in polycythemia, the RBC number increases, so the packed cell volume increases. Okay, this is just illustrative for you to understand it. Okay. So the next is hemoglobin. Okay. Whenever we talk of RBCs, we talk about hemoglobin because hemoglobin is an integral part of the RBC. Okay. So any decrease reflects an RBC result, and any increase also reflects an RBC result. The same is a packed cell volume, as I told you now. They also reflect RBC results, whether they increase or decrease. Okay. Next is what you call as erythrocyte indices. Okay. Indices, mean corpuscular volume. Mean corpuscular volume. What is the volume of each RBC? That is what we call as MCV, or mean corpuscular volume, which is measured in femtoliters. Femto is 10 raised to -15. Okay. So if it decreases, it indicates that RBCs are smaller in size than the normal. That means RBCs are microcytic. And this may be caused by any iron deficiency anemia or due to any thalassemias. If it increases, it indicates that RBCs are larger, that is, they are microcytic. For example, again, anemia caused due to vitamin B12 and folate deficiency. You got megaloblastic anemia there, okay, and myelodysplasia, liver disease, and disease. The next is MCH, that is mean corpuscular hemoglobin. Mean corpuscular hemoglobin means how much hemoglobin is present in each RBC. Okay, what is the weight of the hemoglobin? Okay, so it actually reflects the MCV results, whether it's decrease or increase. A small red cells will have, okay, if the size of the MCV is small or decrease, then MCH is small, because we are saying how much hemoglobin is there in per cell. And if it is the size is large, then the microcytic RBC, they'll have more MCH. That is, the hemoglobin concentration will be more. MCHC is mean corpuscular hemoglobin concentration. Here again, okay, it will be low when the MCV is low, and low MCHC indicates hypochromia. Okay, whenever we talk of these cells, we talk of normocytic, normochromic. Normocytic means normal size and shape, and normochromic means having normal stain, or it is having a normal coloration. This is seen especially in iron deficiency anemia and in thalassemia. Okay, and if there's an increased MCHC value, that is a hyperchromia, it is seen in conditions where the hemoglobin is more concentrated inside the red cells, such as any autoimmune hemolytic anemia, in burn patients when there's a lot of fluid loss, in hereditary spherocytosis. Spherocytosis is a congenital order where the cell loses its biconcave shape and it becomes round in shape, it becomes like a spear. That's why we call it as a spherocytosis. So in spherocytosis, the central pallor, which I showed you earlier, will not be seen. Okay. The next is the RBC distribution width. Please remember what we are talking of. We are talking of distribution width. That means the width between the two RBCs that are there. Okay. So if it decreases or if it is normal, it indicates that RBCs are in normal in size. But if it increases, it indicates that there's a mixed population of small and large RBCs. And young RBCs normally tend to be larger. Okay. So especially in anemia, in pernicious anemia, in deficiency, any iron deficiency anemia, in any N-isocytosis. N-isocytosis means there is microcytosis, there is macrocytosis, or there is normocytosis. The shape is not proper. Okay. The size is not proper. That is what is N-isocytosis. Okay. And if the shape is not proper, we call it as a poikilocytosis. Okay. Two terms I'm using here. One is size. Size differs, N-isocytosis. Shape differs, poikilocytosis. Okay. You can have any poikilocytosis, you can have together also. Okay. So this actually causes an increase in the red cell distribution width. Okay. Next is the reticulocyte count. Okay. The reticulocyte count is especially seen in anemias. A low reticulocyte count will indicate that there's a production of, it is affecting the production of red blood cells. Okay. So there is a bone marrow disorder or damage, or there's a nutritional deficiency. But a high count, okay, will indicate that there is bleeding or hemolysis or a response to a treatment due to which more RBCs are being produced. Okay. Please remember, reticulocyte is the stage before RBC is formed, that is an erythrocyte is formed. So they are nucleated. Okay. So coming to the RDW now again. Okay. See, here I'm talking about the RDW again, wherein we can judge the normocytes, macrocytes, and microcytes. Okay. And it is usually increased in vitamin iron and vitamin B12 and other nutritional deficiencies. Okay. It may also be increased when there is a blood transfusion. Okay. See, in dogs, there are breed differences in erythrocyte volume. You should remember this because we are one of our topic is the pet animals. Okay. See, greyhounds have a higher MCV as compared to other breeds. And macrocytosis is seen in miniature dog breeds and standard poodles. Okay. And microcytosis is seen in especially in Asian dog breeds. That is the Akita, Japanese, or Shiba Inu, that's Japanese. Okay. See, just for you to understand what are these breeds, I put the picture of these breeds over here. The first picture is of a greyhound. Okay. It is coming under the category of a hound dog. The second category is a working dog. Okay. That is the Akita. It is a large dog. Okay. It is around 2 to 2 feet 4 inches. And the dog breed, companion dog, that is a Shiba Inu, okay, it is a small breed, okay. It is only around 13 inches, that is 1 feet to 17 inches to 1.5 feet, okay. The lifespans and all that are given just for your interest and for you, okay, to know about it. Just to break away from the routine so that you can understand and you can have a nice pictorial presentation, okay, to refresh your minds. So then, how do we count an RBC? These are all things that will be taught to you in a practical today. But I just want to say something. See, an RBC, each there are 9 squares here. Okay. The total is, there's a newborn chamber, an improved newborn chamber. Okay. There's a 3 mm. Okay. There are into 3 mm. So totally you have 9 mm square total area. And this entire 9 mm square big squares are divided into small squares of 1 mm each. Okay, 1 mm long and 1 mm wide. That is 1 mm square area. Okay, so you have 1, 2, 3, 4, 5, 6, 7, 8, and 9. For counting purpose, we only use the top left corner square, top right square, bottom right corner square, bottom left corner square. Okay, the central square, that is, we call this as a primary squares. The small squares inside here, we call them as the secondary squares. And inside the secondary squares, there are still smaller squares, which we call as the tertiary squares. Okay. Or in some literature, they call it as a large square, medium square, and small square. Okay. So now why I show this picture over here? See, this is a Newborn's chamber. Okay. What a student should remember is that the central platform where we see this, scale which is there, okay, it is slightly lower than the side platforms. So when you place a cover slip, there's a distance or a gap of 0.1 mm between the cover slip and the platform. Okay. So whenever we say volume, we say the volume is of a newborn chamber is 0.1 cubic mm. That is length into breadth into the depth. That is 1 mm into 1 mm into 0.1 mm. So you have mm raised to the power of 3, mm cube. That is what is cubic mm. Okay. So just wanted to show the students what is the depth that we are calculating and how the depth comes in. These are a WBC pipette and these are RBC pipette, which you all know, just for your information. Okay. These are the areas where blue is shown, where you count the WBCs. Okay. And these are the red areas where we count the RBCs. So let us come now to the analysis of the WBC count. Okay. See, other than using the hemocytometer for counting a WBC, okay, we can, other than using a hemocytometer for counting a WBC, we can make a smear of the blood and study for the differential leukocyte count. Okay. So how to make a differential leukocyte count? This is very important. That's why I show just a drop of slide. Take another slide, keep it at 45 degrees angle. Okay. And pull the smear. Pull. Catch up. Don't push it. Okay. Don't push. धक्का नहीं मारना है, इसको खींचना है. Okay. If you push, what happens? Imagine yourself standing before a truck and the truck pushes you. Then you get crushed, so the cells will break. But if you are below the truck and if you are being pulled, you will get pulled for some area. Okay. So you have to pull it. Okay. That's why I show this. Of course, this is a staining over here. Here, if you can see in the staining, okay, how do you understand that the stain is, your stain is over and it is done? You can see a silver tinge on the smear. Okay. Because of the Leishman stain or the Wright stain. Okay. When it takes the stain. So after staining, this is how the slide should look. Okay. An ideal slide, it should look like this. There should definitely be a tongue. This is a thin film you can make. You can make a thick film. Okay. Based on what is your need. Okay. Now, what are the differential cells? These are the differential cells. On the top are the pictures. Below, I am showing you what are the actual pictures. I have just magnified it so you can see properly. Okay, this is a neutrophil. You can see there are different lobes, okay, multinucleated. And here in between, you can see a thin thread, okay, between the nuclear lobe, a nuclear thread. Okay, there's a eosinophil, bilobed. Okay, again, you can see a thread. Okay, but what is more important is, okay, if you are not appreciating here, you can appreciate on the top figure, there will be eosin granules which are present. Okay, small size. That is why you call them as granulocytes. And there's a basophil. It takes a bluish stain. Okay, I show the picture over here. This is a basophil. Okay, right? And again, you can see a number of cells over here. See the cell. It is not needed that the granules are away from the nucleus. They can be on the nucleus also. Okay. And then we look at the granulocytes, the monocyte, okay, which is a large cell, okay, probably the largest cell, it's around 30 to 40 microns, okay. And we have the lymphocytes, okay. We have two types of lymphocytes. I'll show you in the next slide, okay. See, a neutrophil is around 10 to 15 microns, a eosinophil is around 10 to 12 microns, a basophil is also around 12 microns, okay. A monocyte is around 30 to 40 microns, and a lymphocyte is around 15 to 30 microns. A small lymphocyte is around 6 to 9 microns. Okay, so this is a picture, a blood picture what I am showing you. Okay, this is a neutrophil. You can see this is a neutrophil, 1 lobe, 2 lobe, 3 lobe, 4 lobe. Okay, I think here there's a 5th lobe. Okay, this is an eosinophil. You can see the eosin granules. This is a basophil. Okay, and then we'll come to this. This is a band cell. This is a juvenile neutrophil, a band cell. Okay, where the lobe has still not formed. And this is a monocyte, a large cell, a monocyte. Okay, and this is a small lymphocyte, 7 to 12 microns, a small lymphocyte. And this is a large lymphocyte, okay, around 12 to 16 microns, okay, a large lymphocyte, or even maybe larger, okay. In a small lymphocyte, the nucleus is more, 90% of the cell is nucleus, only 10% is the cytoplasm. In a large nucleocyte, the amount of cytoplasm is more, okay, and the cell is more to the periphery, towards the central side, okay. What happens now? Let us come to the diagnosis. Okay, if there's an increase in leukocytes, WBCs, it's called as leukocytosis. And if there's a decrease, it's called as leukopenia. So if there's any infectious diseases, okay, bacterial or viral, if there's asthma, if there's allergy, if there's intense exercise, okay, your spleen gets contracted, okay, it's leukemia, trauma, burn, myeloproliferative neoplasms or inflammation, all this causes leukocytosis. Whereas the decrease in leukocytes occurs, okay, when there's aplastic anemia, when there's an overactive spleen, when there is a DAG, okay, any viral diseases like feline leukocyte virus, feline enteritis or parvovirus, ehrlichiosis, hereditary conditions like panleukopenias and single leukopenias, okay, lymphoma and bone marrow and immune system diseases. Okay, now see what we are saying. We are saying leukocytosis means the number of WBCs increase. See, the number of WBCs can increase because of the number of any one of the component of the WBC. That is, it can increase either because lymphocytes increase or neutrophils increase or monocytes or eosinophil or basophils decrease. Okay. Similarly, a decrease can occur because of any one of these components increase or decrease. Okay. So we need to look at them individually. Okay. So an increase in the number of lymphocytes is what is called as lymphocytosis. Okay. Chronic infections, allergic reactions, acute viral infections, certain bacterial infection, toxoplasmosis, lymphocyte leukemia, okay, stress, all this causes increase in lymphocyte count. And the lymphocytopenia occurs because of infectious diseases, okay, increased lymphocyte destruction because of neoplasia and due to lymphocyte loss. Neutrophilia occurs due to infectious diseases. See, due to infectious diseases, what I said, lymphopenia occurs. Neutrophilia occurs. Okay, here lymphopenia occurs. But what did we say overall? Leukocytes increase. Okay, why does the leukocyte increase? Because there's an increase in the neutrophils. Okay, right? That's why I'm putting it in bold. Okay, so can be increased marrow proliferation, redistribution among the body neutrophil pools, stress, corticosteroids, acute bacterial infection, inflammation, trauma, burns, okay, Cushing syndrome. All this causes neutrophilia, whereas neutropenia is caused by increased marrow proliferation, ineffective bone marrow, okay, production, reduced neutrophil survival, redistribution of neutrophils, bone marrow damage, cancer that spreads to the bone marrow, and due to congenital neutropenia. Okay. How does an eosinophil occur? See, even eosinophil occurs in increases in infectious diseases. Okay. Allergic reactions, hay fever, which is actually allergic rhinitis. Okay. Parasitism, the most common symptom of parasite is increase in eosinophil. When you go to a doctor, they say eosinophilia ho gaya. Okay. Right. Normally, small kids, they will be having eosinophil increase because of the parasites which are present, endoparasites which are present in their intestines, okay? And common symptom is they'll be coughing, they cough a lot. Okay. Skin diseases, neoplasia, adrenocortical insufficiency, asthma, drug addictions, reactions, Addison disease, and any connective tissue disorder. Okay. All this causes eosinophilia. Eosinopenia may occur due to stress, Cushing syndrome, steroids, and pathological causes, which include burns and acute infection. Okay. Monocytosis. When does the number of monocytes increase? Any trauma, autoimmunity, any disease with significant tissue destruction, stress, infection, hemorrhagic disorders, any gastrointestinal disease, necrosis, and hemolysis. Okay, I'm just reading through because I am running short on time. Okay, monocytopenia occurs in acute infections. Okay, treatment with glucocorticoids, aplastic anemia, hairy cell leukemia. What is hairy cell leukemia? Hairy cell leukemia means where the cell has got, okay, they look like they have got hairs on them. Okay, that means the cell becomes irregular in shape, okay, and the structure, and it will look as if the cell surface has got hairs on them. That's why we call it as hairy cell leukemia. Acute myeloid leukemia, treatment with myelotoxic drugs, or any genetic syndrome. Okay, monomax syndrome. Okay, you can ask Dr. Anshu in genetics. He will explain more to you. It is due to an autosomal dominant gene. Okay, and the main characteristic of this autosomal dominant gene monomax is that it causes a decrease in monocytes, that is monocytopenia. Basophilia, okay, infections can cause basophilia. It is seen very rarely. Okay, severe allergies, overactive thyroid drug, okay, a chronic inflammation, and a rare allergic reaction, leukemia, and even uremia. See, basophilopenia, okay, the numbers are low in the blood. Even if the numbers are low in the blood, okay, since the numbers are low in the blood, it is not very significant. See, you will see only around 1 basophil per 200 cells. So we say it is around 0.5 to 1 cell in 100 cells. Okay, so the number is very low. So medically, I don't think it is very significant. Okay, so then that is all about that. Okay, what did we look in? I'll just go back again. Okay, I will just revise. We looked at what are the different type of cells. Okay, we looked at what are the different type of cells. We looked at what happens when there's leukocytosis and leukopenia. We looked at what happens when there's lymphocytosis and lymphopenia, why it occurs, why neutrophilia and neutropenia occurs, why eosinophilia and eosinopenia occurs, why monocytosis and monocytopenia occurs, why basophilia and basophilopenia occurs. Okay, so we come to the next concept. Okay, I said you need an absolute leukocyte count. Okay, what is an absolute leukocyte count? See, suppose the total leukocyte count is 10,000 per cubic mm. Okay, and you have done a DLC, you have done a differential lymphocyte count, and you have found that the neutrophils and lymphocytes are 35, 55, monocytes are 4, eosinophil is 5, and basophil is 1. Okay, so what does an ALC say? An ALC will say you have to multiply that percentage, okay, at 10,000, okay, and you say that you have got 3,500 neutrophils, 5,500 lymphocytes, okay, 400 monocytes, 400 eosinophils, and 100 basophils. This is what it indicates, okay. I'm not giving any other example over here because I'm running short of time, okay. I'm just explaining to you what's a DLC and ALC, okay. So analysis of platelet count. Now, what does a platelet look like? See, you can count the platelet, okay, either in the primary central square, where I'm showing as PPP, or you can count them in any one of the primary corner squares also, okay. Need not be in any one area, okay. So in any square that you count, the total volume is 0.1 cubic mm, okay. So you should remember that, okay. So what are the methods used? I'm talking about this, the methods used here, because there are two methods. One is a microdilution method and the other is a macrodilution method. Okay. And what I want to remember over here is we use a Rees-Ecker fluid. Okay, Rees-Ecker fluid. See, a Rees-Ecker fluid contains brilliant chrysal blue. Okay, it contains sodium citrate and it contains formaldehyde. Okay, what does a formaldehyde do? It keeps the cell in shape. Okay, what does a Rees-Ecker fluid do? It helps to destroy the RBCs. Okay, right? So you can see the platelets easily. Okay, the micro and macro dilution methods are simple. Micro dilution method is you use a WBC pipette or use an RBC pipette. Okay, you take it up to 0.5 mark. Okay, and platelet diluting fluid, you take it up to 11 mark. The dilution becomes 20. Okay, charge it onto your Neubauer's chamber. Now here one thing you should remember, after charging onto the Neubauer's chamber, you should keep it in a Petri dish with a wet filter paper. Okay, it should be kept moist. The slide should be kept moist, otherwise it will dry off very fast. Okay, that's why what you should do is, what we do in our lab is, we take a Petri dish. In that we keep filter paper. We wet the filter paper and keep it. On that we keep two small sticks, and on the top of that stick we keep the slide. So the slide does not get wet, and then we close the Petri dish. So whenever we want, we can see it, and what happens, the platelets can be counted easy and they do not become dry. Okay. So using a pipette is what is a micro dilution method. But instead of, if you don't have a pipette and you still want to do a count, you can use directly, you can take 3.98 ml of platelet diluting fluid, the Resecker fluid, and in that you can put 20 microliter of blood specimen. That is, you use that. Okay. And then what you can do is, again, the same way, you can your pneumos chamber. You count, and you check the microscope, you can count. Okay, right. So now, okay, the calculation here is you have to, whatever cell you are getting, you have to multiply by 1000. Okay, that is the factor that you get. Okay, so 1000 Y. So how many number of cells you have counted? That's by Y. Okay, I'm showing you here. Okay, I think you can see it. Okay, the slide has changed. Yes, you can see all this blue things. Okay, these are the platelets. Okay, these are the RBCs which are being hemolyzed or on the way to being hemolyzed. Okay, the platelets will be in various shape. There is nothing, no specific shape. It can be a comma, it can be a dot, it can be a round, it can be elliptical shape. Okay, because you should remember, from a megakaryocyte, it is breaking off, so it can break in any shape. Okay, right? So that is why we say we can see in various shapes. So what happens if there is thrombocytopenia and thrombocytosis? Okay, if there's thrombocyte platelets, when it's decreased, is called as thrombocytopenia. So it is a viral infection. Okay, mononucleosis. Mononucleosis, where the mononuclear cells, that is lymphocytes and monocytes, they increase in number. Platelet autoantibody, drugs, cirrhosis of the liver, any septic condition, autoimmune disorders. Okay, you have a condition which is called as immune thrombocytopenic purpura. Okay, immune thrombocytopenic purpura. It is a platelet disorder, ITP. Okay, many times you can see small purple patches under the skin. This may be because of a small capillary blood vessel breaking, or because of platelet disorder, due to which blood is coming out. Okay, right? Leukemia, lymphoma, myelodysplasia. Okay, and over here, and chemotherapies. Okay, and an increase can be in thrombocytosis, called as thrombocytosis. It can be due to cancer, rheumatoid arthritis, an inflammatory bowel disease, lupus. Lupus is an autoimmune disease that affects the lymph nodes. Okay, iron deficiency anemia, hemolytic anemia. Okay, myeloproliferative disorders, which is called as essential thrombocythemia, where the number of thrombocytes increase. Okay. Okay, excuse me. Yeah, are we back on screen? Okay. So what is a mean platelet volume? Okay, mean platelet volume. It is measured in femtoliter. Okay, and it indicates the average platelet is small. Okay. See, the low MPV means the condition is affecting the production of platelets by the bone marrow. Okay, and then high MPV indicates that there are large platelets. Okay, younger plates are larger in size. Okay, and this may be due to any bone marrow, due to bone marrow producing or releasing platelets rapidly into the circulation. Okay, platelet distribution width is only used for research purposes. Okay, indicates uniformity in size of the platelet, and if there's an increase, it indicates there's a variation in the size of the platelets. Okay, so this is all about the blood pictures. These are the various references from where I have taken up this. Okay, and to tell you, all the pictures that I've taken are from the internet. Okay, right. We'll go faster. We'll go ahead. Okay. So now we don't need to do into this all these things. So now what do we need? We have an hematology analyzer technology. Okay. So what is the main principles on which the hematology analyzer technology works? Okay. It works on electrical impedance, flow cytometry, and fluorescent flow cytometry. Okay. Right. I'll come directly to what is electrical impedance. Okay. See, what is electrical impedance? The whole blood is passed between two electrodes through an aperture which is so narrow that only one cell can pass through at a time. So then the impedance changes as the cell passes through. And the change in the impedance is proportional to the cell volume. What is the cell volume? This will result in the number of cell count, okay, and the measure of the volume. Okay, so electrical impedance is mainly seen in three-part hematology analyzer, where you get only granulocytes, lymphocytes, and monocytes. Okay. The next is the flow cytometry. When you use a laser flow cytometry. Okay. Here, what is happening? A single cell stream passes through a laser beam. Since it passes through a laser beam, you can identify even different types of granulocytes. Okay, so you can use it for a 5-part WBC differential. That means if you have a 5-part hematology analyzer, you can see neutrophils, okay, all the granulocytes, eosinophils, basophils, and then you can see the lymphocytes and you can see the monocytes. The next is a fluorescent flow cytometry. Okay, fluorescent flow cytometry is where fluorescent reagents are being added. Okay, and additionally to this, they'll help you to analyze the platelets, they'll help you analyze the nucleated RBCs and also the reticulocytes. Okay, right? So basically, you have 3 types of automated analyzer. Okay, other than the semi-automated and fully automated, there are 3 types of automated analyzers. Okay, the first is the 3-part, 5-part, and 7-part. In the 3-part, you can get the granulocytes, lymphocytes, and monocytes as far as the WBCs are concerned. In the 5-cell part, you will get the neutrophil, eosinophil, basophil, lymphocyte, and monocyte. And in the 7-part, you will get nucleated RBCs additionally, and abnormal or typical and immature cells. Okay. So this is a hematology analyzer. Okay. This is something which is very much present in your department, in Junagadh Physiology department, the 3-part hematology analyzer. You can, in the afternoon, you should please have a look at it and you should know how it is. Okay. This is a 5-part analyzer. I think this Abacus 5-part analyzer is also present in your college. Okay. I don't know in which college, which department. I think it's a pathology department. Okay. It is there. Abacus, a 5-part analyzer. Okay. Your teachers will tell you what is the difference and which is more advantageous, hematology 5-part or 3-part. Okay. And this is a 5-part analyzer, a recent one which was purchased here. Okay. A HemaRay. This is Rato. Okay. A 5-part hematology analyzer again. Just showing you what is an analyzer to give you an idea about it. Okay, so this is a result of a 5-part analyzer. Okay, you can see what all is being measured: WBCs, neutrophils. Okay, the numbers, the percentages, RBC, hemoglobin, hematocrit, MCV, MCH, MCHC. Okay, RDW, RDWSD. Okay, platelets, MPV. Okay, and PDW. Okay, right. So you can see around 26 to 29 parameters over here. Okay. In a 3-part analyzer, you can determine, okay, you got animal settings, you got 3 animal settings. That is, you can set your blood. See, your blood may come from a cow, it may come from a rabbit, it may come from a goat, or it may come from a monkey or from a camel. So accordingly, you have to set your machine to that particular species. And then you can take your readings, okay, before you put in your micro blood. Only 20 microliters of blood is needed, very small amount. Okay. Additionally, you can program for any 3 animals as per the need of the clinician. Okay, right? But some hematology analyzers are there which shows only around 2 or 3 predetermined species, mostly the ruminants and dog. Okay, a cow and sheep and dog or like that. Okay, and may also show any other which you want, you can program, or 2 or 3 you can program for them. Okay, right? So then, what is the normal value in domestic animals? Okay. Excuse me once more. Yeah, we are back on screen. Yeah. So see, these are the normal values. I have given you values of varied species: cattle, buffalo, sheep, goat, camel, horse, pig, dog, and cat. Okay. These are things that I have collected over a number of years from different books. So there's no particular reference I can say. Okay. So there are 2 things here. One is the, other than the blood volume, which is around 6 to 7%. Okay. You can see the blood volume in camel is around 9%. 9.3 is what exactly the literature I read, but I put it as 9. Okay. In horses, it's around 10 to 11. Okay. See, you can see one thing I want to tell you about here in the RBC, the size of the RBC diameter, 5.8 microns in the cattle and buffalo. You can see in sheep and goat, the size of the RBCs is very less, 4.5 and 3.2. Okay. So correspondingly, you can see the total erythrocyte count in sheep and goat is high. It's between 8 to 16 and 8 to 18. Okay, right. So if you say the total erythrocyte count of cattle is 6 millions, okay, or 6, okay, 6 into 10 raised to 6, it should be. It is put as 10 raised to 3, okay, 6 millions per microliter, okay. If you say the total is 6 million, it is normal. But if you say for a goat, it is 6 million, please remember it is anemia. The goat is having less number of RBCs. Okay. The second is the RBC lifespan that I want you to concentrate on. Okay. Right. See, the dog, again here, as far as the dog erythrocyte is concerned, it's 7 micrometer. Okay. And this is equivalent to the human micro RBC, which is also around 7.5 micrometer. Okay. And the lifespan of animals, okay. So here what I'm trying to show you is the lifespan of RBC in cattle is 160, okay. The lowest is in pig, in cat, which is 70 days, okay. So I'm showing a lifespan of RBC in camel as 90 to 120 days. This depends upon whether it's a rehydrated condition or dehydrated. Okay, I said two things, or let me say dehydrated, dehydrated or hydrated condition. Okay. And an RBC in a camel is also 7.7 into 4.2. I told you it's biconvex elliptical. Okay. Now, why does this shape vary here? Okay. Right. See, again, we are talking about the ESR. Okay. In horse, we say 10 to 15 per 20 minutes. The number is more. I told you about the Rolex formation. Okay. See, the lifespan in an RBC actually depends upon his hydration. Okay. Yagil, very great scientist who worked on RBCs in all camel. He has got a number of papers. Okay. He said the shortest lifespan is located in winter, that is in a hydrated state. Okay. Whereas the longest lifespan is in summer, that is during chronic dehydration. Why is the lifespan during summer long? He said this is because the camel tries to preserve water. So the lifespan is more. Okay. Further, in other study, they have said that the cell size diminishes. The shape will not diminish. Okay, when there is dehydration. But after rehydration, the cell size will increase again. It may probably become round also. Okay. So we now come to our latest reference on morphometry of RBCs. See, Nezer in 2016, he saw around 50 animals from each species: bovine, goat, horses, and dogs. Okay, right? He saw the diameter. He gave two additional parameters, that is the circumference and the volume. Okay, the surface in micro square meter. Okay, this is what it is. It's already something equivalent to what we have seen. Okay, but this and actually this thing. Now, what does Nezer say, or what is he concluding? See, when you get a blood smear and you are not able to identify which animal blood smear it is, see, the size of the RBC will help you in determining the species of the animal. Okay, because you know the ovines and goats, the size is small. Bovines, it is large. Okay, right. How do you study the morphometry of an RBC? We use an ocular micrometer. Okay, the ocular, I have not put it over here because I didn't think I could be able to cover it. Okay, you can have a normal microscope in which you can put you can put the scale into the eyepiece, and you can carry it on the stage also. Okay. You can also use an electron microscope, a scanning electron microscope, or a TEM microscope. Okay, and your electron microscope is also there in your, I think, agriculture college in Junagadh. Okay, you can go there. You can keep cells, and that gives you very nicely. Okay, right. Now, this is a study that I did. I told you I worked in Gir and Jafrabadi breeds. Okay. See, we tried to establish the normal values. Okay. And I started blood collection from 1 week of age. Many up to 1 week, 1 month, 3 months, 6 months, 12 months animals. Okay. and also animals in lactating stages, in non-lactating stages, pregnant, non-pregnant, okay, different things. But see, what I'm trying to tell over here is, see, at the initial stages, at 1 week of age, okay, right, the erythrocyte count, whether it's a Gir male or female or Jaffrabadi male or female, okay, it is higher than in an adult stage. Okay, the RBCs in a neonatal animal are higher than that which is seen in a 12-month-old, or actually by 1 month they become normal. Okay, right? That is what I'm trying to stress. So over here again, hemoglobin and PCV is also higher. Okay, corresponding to the RBCs. Okay, so let's go to the normal values of WBCs. Sir, I'm back on. Can you hear me? Hello.
Sir.
Can I start slide sharing?
Yes, sir. Please.
I'm sorry.
Please share your slides.
Yeah, I'm sorry for the inconvenience and the sudden my computer hung up. Maybe because it's got
It
a lot
happens
of
due to internet connection, sir.
yeah, could be. No, internet connection is okay, sir. I'll just come in again. Yeah.
Okay,
I'm
sir.
sharing my screen, sir. Yes, sir. Is the screen visible?
Yes. Yes. Yes, sir.
Okay, sir. Okay. So we were talking about WBC, okay? So what happens here? See, in cattle, buffalo, sheep, and goat and camel, the lymphocyte numbers are more, and in the horse, that is the ruminant animals, lymphocytes are more, okay? And in the non-ruminant animal or the simple stomach animal, the neutrophil numbers are more, which is what we are stressing over here, okay? So again, I had done a study on 1 week and 12 months and different ages, as I told you, in Gir and definitely in Jafrabadi buffaloes, Gir cattle and Jafrabadi buffaloes. See, to my surprise or to our surprise, what we found out was that the neutrophil numbers at 1 week of age are more in both the Gir female and male and Jafrabadi female and male. Okay, we normally say that lymphocytes should be more in ruminant, but here at 1 week the neutrophil numbers are more. Okay, we can see here, and the lymphocyte numbers are less over here. See, the neutrophil is more, lymphocyte is less. Okay, but when it becomes an adult animal again, the lymphocytes are more and the neutrophils are less. So in a pre-ruminant animal, the pre-ruminant stage, the neutrophil is what is more in number. That is what I am trying to stress over here through this figure. Okay. Next is hemoglobin estimation. Different methods are there: manual method, automated method, sign methemoglobin method, and acidimethin method, okay, which is ferric heme chloride. And automated is through the Coulter counter method, okay. Sign methemoglobin method is actually using Drapkin solution, okay, wherein you use potassium ferricyanide with potassium cyanide, okay. And what happens is it converts the hemoglobin to methemoglobin, which then is converted to hemoglobin cyanide, which is what is called a sign methemoglobin, okay. And this is measured at 540 nanometers. See, it's more reliable method than a manual method, that is a Sally's acidimethin method, because there it depends upon human error. Here it is basically based on a machine, okay. The pack cell volume, these are the Winthrop tubes, pasture pipettes, okay, and the Winthrop tubes which are used, okay. Erythrocyte sedimentation rate, see, I show 3. This is an erythrocyte, okay. This is a Westergren pipette, and this is a Westergren stand, okay. You can see what I'm showing here. The distance in mm, the RBC fall in 1 hour is the sedimentation rate, okay. And now we have got this graduated ESR rack with pipettes. We got SRite rack and SRite pipettes over here. Okay, ESR, right? That is SRite. Okay. So what you can do is you can just fill up blood into one of the small container over here. Into this container, you can fill up blood, and then you can push in the pipette inside the blood, and the blood can rise. Okay, there is no graduation on the pipette. The graduation is on an aluminum plate which is behind, okay, in which you can see the different graduations, and based on which you can find out what are the different estimations, you know. So what is the different level of ESR? Okay. So what is the importance of ESR? Okay. Normally, when you look at a CPC also, you will not get a ESR value in that. Okay. What is the importance of an ESR? It is not diagnostic of any particular disease, but it indicates that there's a disease in the body and it needs to be diagnosed. Okay. So it's a non-specific screening to detect infection in the body and to monitor the progress of the disease, especially rheumatoid arthritis, tuberculosis. Okay. In all these conditions, ESR is increased. Next, you come to bleeding time, which of course will be taught to you. Okay. But in dogs, we do the buccal mucosa bleeding time. Okay. and it is bleeding time is the time from which the blood starts to flow till the time the blood stops. Okay, in humans you can use the finger tip. Okay, here we can use the buccal mucosa, or we can use the toenail also. Okay, so what does the bleeding time indicate? It indicates that there is a platelet defect, function defect if it is a prolonged bleeding time. Okay, it indicates blood vessels defect. It indicates the disease of von Willebrand of this factor, that is factor 8. It also indicates hemorrhagic phase of the disseminated intravascular coagulation. Even if there is aspirin or anti-inflammatory drugs, bleeding time will increase. So you should be very careful. If there is any bleeding taking place in your body, you should not take aspirin or Dispirin. Okay, right? In normal in dogs is around 2 to 4 minutes. So I'm showing figures over here. Okay, this is the buccal mucosa. The dog should definitely be muzzled. It should be tied. Okay, and the bleeding is taken. It is just a small cut is made. Okay, and the blood, from the time the blood appears till the time blood stops to flow by itself. Okay, the toenail clipping can also be done. Okay, from which the bleeding, the blood can become. See, it should not be very small drops, or it should not be a jet-like flow. Okay, just in the medium that you can do it as with the experience. Okay, this is how bleeding time can be seen in dogs. Okay, okay. And now I wanted to talk about the platelet and coagulation disorders. Okay, so you can see that in prothrombin time is increased in vitamin K deficiency. Okay, is increased in liver failure and early life stage. Okay, and also in uremia. In DIC, that's disseminated intravascular coagulation, and in hyperfibrolysis. On all this time, the thrombin time is increased. Okay, this is what I wanted to mainly stress over here. Here I'm giving you in another slide where I put it in bold what is prolonged in which area. Okay, this may mostly interest PG students. If you want, you can take the slide from your department. Okay. See, what is clotting time now? Okay, we talked about bleeding time, we talked about clotting time. So the time required for blood to clot when a cut or a prick is made, that is a clotting time. So for clotting time, you have 3 different methods. One is the capillary tube method, second is the slide method, and third is the activated clotting time. Okay, so in normal dogs, the clotting time is less than 120 seconds, and in cats, it's around 165 seconds. Okay, what are the factors which prolong clotting time? The deficiency of any of the clotting factors, 5, 7, 8, 9, 11 or 12, vitamin K deficiency, hemorrhagic DIC, heparin therapy, low platelet count, anticoagulant treatment. Okay, all this what increase the clotting time. Okay, so there's a fibrin that you can see. This is a capillary tube method. This is a slide method wherein you can take blood and you can put it on a slide, and then you can slowly pick it up to see when a fibrin is available. Okay, this is an activated tube. You can get serum clot activators. Okay, or you can get tubes which are having serum clot activators. Okay, what is the activator that is used? Thrombin is used. Okay, so when you put blood inside, it will act, it will clot. Or simply you can take a tube, a large tube. This is how I did my MBSc. Took a large tube with around 8 mm to 10 mm diameter. Okay, fill blood inside, and then just either tilt it or keep it like that. When the clot forms, the clot will shrink, and serum can be easily and nicely removed. Okay, right? The whole blood clotting test. Okay, so what is the coagulation time in domestic animals? In cattle, it's around 6.5. In sheep, 2.5. In horse, 11.5. In pig, 3.5. In dog, 2. Okay, 120 seconds is what I gave you earlier. And in cat, 2.5 to 3.0, that is 165 seconds is what I gave it. Okay. See, what is the importance? See, we don't do so regularly bleeding time and clotting time, but in humans, bleeding time and clotting time is definitely determined before surgery. Okay, especially if you're on blood thinners. So when you're on blood thinners, the main time that is seen is the prothrombin time. Okay, what is the prothrombin time? It measures the number of seconds that's taken for the clot to form in the blood sample after some substances are added to it. Okay. Now see, this prothrombin time actually shows you both coagulation factors, both the intrinsic factors as well as the common pathways of coagulation. They cascade together and they show the effect. Okay. So the prothrombin time is a test to evaluate the animal's ability to form clots, properly formed blood clots. Okay. Now, since what happens, the prothrombin time or the substances added from one laboratory to the other laboratory varies, we have an international normalized ratio, which is actually the prothrombin test time divided by the prothrombin normal time. That is what they say in the laboratory, raised to the power of ISI, that is the International Sensitive Index. Okay, and then you get a prothrombin time. Okay, now see what is an international normalized time. Okay, see I'm putting two strips of papers, results, okay, of prothrombin in INR. Okay, this is my mother's results. Okay, and I'm just putting a portion of that for you to understand. See, the prothrombin time, the test is shown as 21.9. The normal should be 10 to 14 seconds. Okay, the control in their lab is 13.3. So what did we say? Test divided by control raised to ISI. Okay, what was ISI? International Sensitivity Index. Okay, ISI, International Sensitive Index. You can see the last line at the bottom. Okay, so we come back to the slide again. Okay, so right, the ISI is 1.21. So the INR is 1.83. What should be the normal INR? It should be 0 to 1.0. This is about humans, I'm telling. Okay, right? Here, what is the INR? It is 1.83. See, if you are on a blood thinner, if you are having any blood thinner like aspirin or acetone or any blood thinner, okay, the INR can be around 2. It can be considered normal. Okay, but see, here is again, okay, another date, another prothrombin time, prothrombin control, and INR. Okay, is 1.2. Here it was 1.83. Here it is 1.2. The normal should be 1.0 to 1. Okay. See, till your INR becomes normal, a doctor will not do any operation on you or will not touch you. Okay. Even if you want to do simple tooth or you want to do a dental, you want to do anything also, they'll ask you to get your INR back to normal first. Okay. So we come to the last topic for today, which I thought should be interesting to students. That is blood groups in animals. Okay, I'm extremely sorry for taking extra amount of time, and I apologize to my next speaker also. Okay, see blood groups in animals. Okay, see they have diverse groups, making it difficult to have a complete typing of the blood group. Unlike humans, where you have the ABO group, ABO. Okay, that is in humans. In dogs, see there are around 12 blood group systems. But they are mostly typed for DEA. What is DEA? Dog erythrocyte antigen 1.1 and dog erythrocyte antigen 1.2. Okay, cats are typed for A and B groups. Okay, cat have 3 groups: A group, B group, and AB group. Okay, right. So commercial kits are available both for DEA 1.1 and DEA 1.2, and for cats A and B groups. Okay, right. So cross matching in dogs, please remember, the first time you do blood transfusion in any animal, you don't need a cross matching because of the varied amount of blood groups. Okay. But a second transfusion, especially in dogs, you need to have a blood matching. Okay. So we have a condition which is called as neonatal isoerythrolysis, where a DEA1 negative female dog, okay, which is previously sensitized to DEA1 positive cells. That means it has got already DEA1 positive antibodies in it. If it is mated to DEA 1.1 positive male dogs, then neonatal isoerythrolysis occurs. Okay. Similarly, it is in kittens with type A blood bond to mothers with type B blood. Okay. Right. Like in humans, we say Rh positive, Rh negative. Okay. Here, that is what we call as 1.1 positive and 1.1 negative. Okay. So these are the various blood groups in different animals. Okay. Again, your teacher, Dr. Padodra, was kind enough to associate and help me in writing a popular article in Godarshan Guide. It is in Gujarati. Okay, in 2016, where we wrote about the different blood groups in animals. Okay, from various references. The references are given on the site. See, in cattle there are 12 blood groups. Okay, I'll not go into reading the different blood groups. In buffalo there are 7. In goat, there are 6. In sheep, there are 7. In horse, there are 8. Okay. In pig, there are 11. And in cat, okay. In cat, there are 3. And in dog, there are 13. Okay. Right. Sorry, I'm getting a lot of disturbance. Yeah. So what we are saying, we're saying of 12, 7, goat 6, sheep 7, horse 8, pig 11, cat 3, and dog 13. Okay, right? This is what we did. We collected from various sources and we put it as a popular article in Gujarati in Gaudarshan Guide. Okay, what is it that I am trying to stress on? Okay, it's recently now Tanuvas in Chennai, Tamil Nadu Veterinary and Animal Sciences University. Okay, they have come out with a blood bank for canine blood. Okay, see, they do over 200 transfusions every year. And now they have developed an app which is called as a Day-4 pet app. It's a mobile app. So what you can do, you can bring together all the pet owners, all the pet owners or the parents. I put them as pet parents, okay, because the pet owner is normally like a parent to them, okay. So they can register themselves and the dogs along with the name, the dog's breed, the weight, and the address. Okay. So if there's any emergency, it will help the pet owners to find, okay, a suitable donor for their pet, or they can even donate blood. Okay. So dogs, they have, see, DEA1 is mainly two types, DEA1 negative and DEA1 positive. Okay. Please remember, DEA1 positive means it has got an antigen, okay, positive antigen on it. Negative means the antigen is not present on it. That's why you call it as a DEA1 and negative, okay, right? But see, the native Indian dogs, around 70% of them, Chippipari dogs, okay, as per the Professor Tirumurugan from Animal Biotechnology Department, okay, they are DEA1 negative. Okay, this is what I'm talking about, the report in the Hindu, which was published on October 4th, 2019. Okay, so there's what you should remember is now blood bank concept has started coming in. Okay, and dogs blood bank is there. I heard someone was telling me that even Bombay has got a blood bank. I don't know, it's in the veterinary college or where it is. Okay, but Tanuvas, the Madras Veterinary College, does have a blood bank for canine blood. Okay, now this is a quick test for how to determine blood groups. Okay, say this is called as Alvedia Canine Quick Test. Okay, Alvedia, it is available at Secure Diagnostics Bhopal. I talked to them and they are kind enough to allow me to use their slides. Okay, so it determines DEA1 antigen. Say a DEA1 positive donor can give blood to a DEA1 positive recipient. Okay, whereas a DEA1 negative donor can give blood to a DEA1 negative recipient as well as to a DEA1 positive recipient. See, please remember what I said. Positive means there's an antigen. Negative means that antigen is absent. Okay, so if that antigen, see, if suppose DEA1 positive is given to DEA1 negative, it will produce an antibody against it. So next time a DEA1 positive blood is given, okay, there will be hemolysis of blood because already the antibody against 1 is present over there, 1.1 is present, and the blood will hemolyze and it will break. Okay, right? That is why I talked earlier of neonatal isoerythrolysis. Okay, so how is this test done? Okay, that is what I am trying to show you. It's called as a quick test. Okay, see, this is the components of the quick test. See, the step 1 is you just remove the slide. Okay, and there's a small well. You add the buffer solution in that, and in another one you take your blood and you got a pipette inside. You got a tube, a strip. That strip you dip into the blood. Okay. And then that blood strip, what you should do is you should dip into the fourth step 4, you should dip into the well with the buffer. So the blood gets diluted over here into the buffer. Okay. Then you have a plastic device over here, okay, which has got 3 parts. In between, one is a capillary region. The 2 parts are one which stands on the 2 sides of the well. Okay, so you just dip it in, okay, and you wait for it, okay, maybe around 2 minutes, and then you can read it. Okay, see, I don't know if it is visible to you. Okay, you can see this is the first one. Okay, there is a the first point over here. This is a control, and here you will have the DEA1 antigen. So if there is no color over here, it means it's a DEA1 negative, and only the control is there. Okay. Secondly, if it is a weak is seen, if only a weak line is seen over here, then it's a DEA1 weak antigen. So normally term it as a DEA 1.2 positive dog. Okay, and if it's a complete line is seen at the DEA1, okay, then we call it as a DA1 positive, okay, right? Similarly, in a cat, you can see, okay, the next slide is about the cat. In the cat, you can see again, okay, there's an A group in the cat, okay. In cat, you'll have A, B, B, A, and C. Okay, the control has to be having a red line. If A has a red line, it's A group. If B has a red line, it's a B group. And if both A and B have red lines, then it is AB group. Okay, that is how it is in a cat. Okay, see, this is human blood grouping. Okay, this was about animals. Okay, I think you understood it. I just tried to introduce what is blood grouping in animals and about the blood bank, which you all as veterinarians should know now. Okay, right? This is blood grouping in human beings. Okay, right? See, I'm showing you first an O positive. Okay, where A antigen pink is blue is the A, it is negative, B here is negative, but RH factor O is positive. And the next I'm showing is an AB positive. Okay, this should cover all the intermediates that you have. Okay, right, in humans. So now see what happens in blood group in O. We say that O is a universal red cell donor, red blood cell donor. Okay, okay, especially group O RSD negative red cells. Okay, they neither have, okay, any RSD antigens in it. Okay, they don't have any RSD antigens in it. Neither they have A, B, or O groups. Okay, and they don't have any antigen in it. Okay, right? So an O group O RSD negative cells, they can be used in emergency wherever any life-saving transfusion is needed. Okay. Now see, conversely, group AB individuals, they are, okay, they have A antigen and B antigen in them. So they don't have any anti-A, they don't have any anti-B. Okay, right. So AB plasma is devoid of any antibodies. So you can use the AB plasma as a universal plasma donor. I'm talking of two things. We say O is a universal donor. Donor of what? Red blood cell donor. And AB is a universal plasma donor. Okay. So definitely RH is named after the rhesus monkey, which you know, and we should always be thankful to Carl Leinsteiner for blood grouping along with Alexander Wiener, okay, who was mainly instrumental in finding the blood groups, especially the RH groups. Okay. So what is the blood groups needed for? Okay, it is needed for blood transfusion. Okay, when is blood transfusion needed? In cases of severe anemia, in cases of iron deficiency, in cases of severe bleeding and shock, trauma, especially in spleen injuries, surgical operations, hypoproteinemia, acute infection, all this necessitates blood transfusion. Okay, right? So I just touched upon blood grouping. Okay, and there's different blood groups. I touched upon blood for pet mobile app, which is being used in Tanuvas. I touched upon LVDA, canine quick DEA. See, every word has a meaning. LVDA is Alice Veterinary Diagnostics. LVDA. Okay, right? So we can get that. Then there's a quick test which I told you about. Okay, and blood grouping in humans. We talked again about the universal blood cell donor. We talked about universal plasma donor. Okay, blood transfusion. So I summarize with a simple 2 lines that hematological tests are primary tool for diagnosis of any disease. Okay, any veterinarian, okay, whether it's in the clinic, whether it's in the college, whether it's in the lab, okay, basically a BVSC, a veterinarian, should be well versed in various techniques and in the interpretation of results to be a successful clinician. Okay, thank you very much. I'm sorry I have taken a little more time, and I'm sorry about getting disconnected in between again.
Yes, sir. Thank you very much for a very nice, informative lecture. A very basic, but you have covered all the aspects of the blood groups in animals. Thank you again, sir. Now the topic is open for discussion. If any participant has any questions or queries, please ask. Ainam, sir.
Yes, sir, please.
I have one query regarding the coagulation time.
Yeah, may I know who is talking, please?
One
May I know
query
who is asking the question? Please introduce yourself.
myself, Dr. M.D. Odedra, and I am session chairman.
Oh, hello, Odedra sir. How are you?
Fine, sir.
I hope you remember me.
Sir, I think that we have worked together at Junagadh. If you remember that time, I have joined the Junagadh in the 1995. At that time, you were working at the NRS.
Yes.
Hello.
Yes, please go on, sir.
Sir, regarding the coagulation time in the animals, the coagulation time in the horse blood is maximum, that is the 11 minutes.
Yes, sir.
What is the reason in it, behind that, sir?
I wouldn't be able to assign any particular reason, frankly, because these are values that I've got from the various sources.
Okay,
what
sir,
is the risk? I don't even know about which breed or species they are talking about. So there's an increased, of course, coagulation time which is being seen in horses. Okay.
Okay, sir. Okay.
I
I came across one case of the autoimmune disease in my nephew, sir, and if you can enlighten something for the early diagnosis of the autoimmune disease, the blood profile of the autoimmune disease, how it differs from the normal blood picture. If you can show some,
humans. Though I am not well versed in, or I am not competent enough to talk about humans.
Okay, sir.
I'll tell you. I'll just show you, sir. See, we talked about. We talked about this, isn't it? We talked about leukopenia occurring in any immune diseases.
Yes, sir.
Okay? One thing. I'm going back to the slide. Okay. And again, autoimmune diseases. One is leukopenia. Other, I think, is. I think there should be more number of, less number of, what do you say, lymphocytes which are there.
Okay.
Neutrophils should be increasing.
Okay. Okay.
Because it is directly concerned with lymphocytes, no? Because lymphocyte destruction will be there. Because any immunity is concerned with lymphocytes, where the B cell and T cells are being seen. So it will definitely reflect on the lymphocyte count.
Okay, sir.
Sir, some queries from the students are there. So we have with the student of first year. They want to ask some queries to you, sir. Please.
I'd be happy if I can solve that doubt, sir.
Good morning,
Please.
sir.
Good morning.
Myself, Ravindra Bodala from Rajasthan.
Hello.
So what is the hematocrit amount and how can we define it in a simple way?
What is the hematocrit?
What is the hematocrit amount and how we define it in a simple way?
Hematocrit amount.
What is the hematocrit amount? And you want to say how we can find it? Hematocrit amount.
I understand this question. Basically, you should understand one thing, okay? See, when we are talking of hematocrit, okay, there are two words. One is heme. The second is crit, centrifuge. Okay, we are centrifuging the blood. And then what we are getting, okay, the packed cell volume, the buffy coat, and plasma. This is actually what is your hematocrit. Okay, but nowadays what we do is the packed cell volume, we go on to talk it as, we call it as a hematocrit. But frankly, if you're talking what is a hematocrit, it's a blood which is centrifuged. And what are the different layers of the blood that you're getting in? That is the RBC, WBC, and the plasma that is there. Okay. See, the plasma is very indicative, which I have not brought over here. The plasma, the color of the plasma changes in different diseases. Okay. The color of the plasma will, if you have got any hemolysis, then the color of the plasma, which is normally straw colored, okay, hay colored, okay. In horse, it is dark hay colored, okay. This will become, if it is hemolytic, then it becomes a green color, if hemolysis is there. If there is lipemia, then it becomes more white in color, okay. But as far as the hematocrit, or if you are specifically referring to the packed cell volume, okay, I showed a slide, okay, wherein I talked to you and I showed you. I showed the slide, if you can see it, okay, wherein we said in the normal blood and how in anemia the PCV decreases and in polycythemia the PCV increases. Okay, if that is what is answering your question. Is there anything else you need a clarification on?
My other question, sir, what is the best source of active bone marrow in a 20-year-old person?
What is the best source of?
So what is the best source of active bone marrow in a 20-year-old person?
Sir, I am not able to hear your question properly.
Where is the question?
I understood what is the best.
His question is what is the best source of active bone marrow in a 20-year-old person?
See, in a 20-year-old marrow, the active bone marrow is already there. Okay? It is there in the long bones and also in the flat bones. In case of any bone marrow disease that you have, then you have to do a bone marrow transfusion. Okay, and the bone marrow transfusion has to be done with a matching bone marrow has to be taken. Okay, and if you have a twin or a sibling, preferably a twin, a bone marrow matching would be, bone marrow transfusion would be very helpful. Okay, so active bone marrow is always there in the bone marrow, in the long bones and in your flat bones. Okay, they become active, and that is what is helping you to produce your cells, your RBCs and WBCs. Okay. In case of any bone marrow disease, you need a bone marrow transfusion. That's again a big topic again. Okay.
Oh, smoking person.
रुक जा थोड़ा। बोन मेरो की हेल्थ के लिए तो पूछ रहा है। बोन मेरो को स्ट्रॉन्ग बनाने के लिए कैल्शियम इज द मेन ingredient you have to take it. The milk as well as the egg is the rich source. Okay, you should take to strengthen your bone marrow and bones. जिसकी हड्डियां मजबूत होगी उसका bone marrow भी strong होगा. So calcium is the main ingredient or nutrition or nutrient that you have to take from your food. समझे? तो जिसमें कैल्शियम ज्यादा होगा अगर वो खाओगे तो तुम्हारे बोन्स मजबूत होंगे और बोन्स जिसके मजबूत होंगे उसके बोन मेरो भी मजबूत होंगे. Okay?
That is, if you are asking how to keep your bone marrow active, definitely.
That was his question, sir.
Then you have to have proper nutrients to keep your bone marrow active.
Next participant.
Good morning, sir. Myself, Vikram Chauhan, for first year student of veterinary science.
Yeah, welcome. Hello.
Sir, my question is after splenectomy, the RBC count in blood is increased or decreased, sir?
After splenectomy, will the RBC count increase or decrease?
Yes, sir.
Okay. Yeah, I understand what you're trying to say. Okay, spleen is actually called as a graveyard for RBCs. Okay, that is why you're asking. Because the spleen has got very, very thin capillaries in them. And when an RBC becomes old, as they pass through the spleen, okay, when it passes through the spleen, then what happens? It loses its elasticity and they get destroyed and they break up. Okay, so that is why your question comes in as whether after splenectomy, where the RBC cells increase or decrease. So remember, all RBCs have got a certain lifespan. Okay, so if it is not, if you are doing a splenectomy or if some part of it is there, the RBCs will get automatically broken down after its lifespan is over. Need not be that it breaks up in the spleen itself. Okay, so what is normally happening is any spleen disease or anything is there. Okay, then the number of RBCs will decrease in size. Okay, and again it depends upon what type of spleen disease you have. Okay, whether that is whether it is something that is affecting the spleen or directly it is destroying the spleen cells, or whether it is something that is leading to the increased in the number of cells. Okay, right? So it is not exactly correct to say that after splenectomy the number of RBCs will increase. Okay, because they all have a certain lifespan.
Sir, one last question from our student, please.
Good morning, sir. My name is Reddy Charatia. I'm first year student. And my question is, what role do corticosteroids play in increasing neutrophil count?
How does corticosteroid?
Sir, he is asking about the role of corticosteroid in increasing the neutrophil count.
Yeah, corticosteroids actually they are immune suppressants. Okay, so whenever corticosteroids are given, the lymphocyte numbers will decrease. Okay, and when the lymphocyte number decreases, there's a compensatory increase in the number of neutrophils. So you should remember that in the field, whenever you are giving corticosteroids, you should always give it under the umbrella of antibiotics. You should not give without antibiotics, because the corticosteroids normally suppress the immunity of the animal. Okay, so the lymphocyte counts will decrease and the neutrophil count will increase. Actually, corticosteroids will also help the erythroid cells to proliferate. It will help the stem cells to convert into the erythrocyte cells, and more RBCs will also be produced in order to meet stress or to combat stress, because you need more oxygen. Okay, so whenever you are under any corticosteroid treatment, and in the field, or even you yourself are under corticosteroid treatment, always remember that your immunity is suppressed. Okay, the B lymphocytes, your T lymphocytes are suppressed. Okay, and you need to be under antibiotic course along with it, so that you are safe. Okay.
Thank you, sir.
Yeah,
So,
thank you.
Thank you very much, sir, for a very good interaction. And I will hand over the mic now session to organizing secretary. He has to say anything. Jacob, sir.
Okay, thank you very much, sir, for your very nice presentation. And especially we learned from your lesson is how to check the blood group of the canines. So this is our new learning, and we will try to use this canine kit for blood grouping from here also. So thank you very much for your nice presentation. And next speaker is our Dr. Smita Pai.
Thank you very much. Can I leave? I could like to thank the organizers. I could like to thank the dean. I could like to thank the vice chancellors. I could like to thank Dr. Odadra, my friend from BPH. He knows me. I used to go into his room a number of times and talk to him. And also Dr. Bhavika Patel, who is on the team. I could like to thank Dr. Padodra also, whom I can see there. Okay. And all participants who have been kind enough to attend this lecture and to listen to it. If you can throw any light on anything or any questions, you can always contact me. You can definitely enlighten me, because life is the learning process. Okay, so I look forward to learn from all of you and to interact from all of you with you. Okay,
so please share about the blood grouping information of the canines. Please share.
I'll send you my slides. Don't worry, sir. I'll send you my slides. You can share
no,
it.
Blood grouping.
Yeah,
I'm talking about the blood grouping of the canines.
Yes, sir. Yes, sir. I especially thought some people will come up and ask me what is the cost of the blood grouping. Actually, see, the cost is very high. It is around 25,000 for 10 tests. which includes a test for a dog and a test for a cat, both 10 strips. So here again, Tanuvas is trying to come up. They are trying to find out a kit through which blood grouping they can do, because and to reduce the cost like that. Okay. So that is another thing. If you want, I can send you the address also from where you can get this. Okay. The secure diagnostics in Bhopal. I can send you their address. I can send you the literature also. Okay. They were kind enough to permit me to tell about this over here. So thank you very much. Yeah.
Okay, thank you, sir. अपना बीजा स्पीकर अभी क्या सर?
Yes. अरे one turn.
Okay. Dear participants, our next worthy speaker is Dr. Sunita Parikh. She is Associate Professor and Head Department of Veterinary Physiology, Rajivas, Bikaner. She graduated in 1999 and post-graduated in 2001 from Rajasthan Agricultural University, and she has completed her PhD in 2020 from Rajivas, Bikaner. She has got 19 years of work experience, and her area of specializations are dehydration studies, body water compartmentalization, plasma volume, extracellular fluid volume, environmental stress, transportation stress, psychological stress, and its impact on the different organs, tissues, and cells, and oxidative stress. Our current area of the workings are multiple stress responses in native breed involving different stressors like psychological stress and environmental stress, body conditioner scoring, environmental challenges and its impact on metabolites and antioxidants. She has published 20 articles, 20 research articles, 11 manuals, 2 training manuals, and 1 review article. She has got first rank in CoVS and A.H, that is the overall rank. She has got the University Merit Scholarship during the CoVS and A.H. She has got 2 national awards as well as the 1 university level award. She is also the member of SAPI, IAWA, RSPC, and life member of the biannual veterinary journal, Veterinary Practitioner. With this brief introduction, I invite Dr. Parikh to deliver a talk or presentation on the hepatic function test and its advancements in veterinary aspects. Please, madam.
Thank you very much. Thank you very much, sir. Am I audible and visible, sir?
Yes, madam. Yes, madam.
Okay. Should I start?
Yes, madam. Please.
Okay. A very good morning to all. Myself, Dr. Sunita Parikh, as you have given my introduction. The topic of my presentation is the hepatic function test and its advancement in veterinary aspects. So this is the beautiful picture of our campus, main campus. Here you can see it is a heritage building. Now regarding the topic, the introduction of this topic, let us, before starting the hepatic function, so let us recall the important functions that are carried out by the liver. So the liver is an screen minimize. Okay. So liver is an organ that performs numerous functions like the synthetic function. We can categorize many functions in this, like the synthesis of the albumin, clotting factors that are first, second, 9, 10, then synthesis of the cholesterol, prothrombin, triglycerides, lipoproteins, and the metabolic functions. It is related with the metabolism of the carbohydrate, fat, and the proteins. In carbohydrate metabolism, it is related with the glycolysis, then gluconeogenesis, maintenance of the blood sugar level. And in fat metabolism, the beta oxidation of fatty acids are carried out. And in proteins, the amination and deamination reactions are carried out here by the presence of various enzymes that are present in liver. And regarding the detoxification or the excretory function, the ammonia, the bile pigments, and the various drugs are related. It is also related with the storage function. It can store vitamin A in ample amount, the vitamin D, K, and vitamin B12. Now, how we can assessment the hepatic functions? There are various modes to assess the hepatic functions. We can go step by step on these. Okay. Now, first is the clinical history. There are many symptoms or many symptoms that are shown by the animal, like there may be the inappetence, diarrhea, vomiting. All these things are, as these are related with many diseases, and also in case of the hepatic functions, there is a recurrent commencement of these symptoms. Then comes the physical examination, that paler mucous membrane that can be seen, that is due to the inappetence, and another signs that is related with its function. And most importantly is the biochemical test that we will carried out in detail. And advancement, regarding the advancement of the assessment of the hepatic functions, there are the hepatic imaging is most important, and the new techniques that are mostly available in the Gadwasu and the Tanuvas campus. And CT scan is, I think, that is available in 5 or 6 universities also. And then the histopathology of the hepatic biopsy and the scintigraphy. Scintigraphy is less commonly used because it uses the radioactive material. Now, the classification of the hepatic function test, or LFT, you can classify in various categories. First is the enzymatic. That is the most important test that tests are mainly related with the laboratory test. Then comes the test related with the bilirubin and a bilirubin related test. Other test, miscellaneous test, and test for the possible blockage of the bile duct. So we can we proceed in this sequential manner of the LFT. Like the first is the enzymatic test, then we will deal with the bilirubin and the bilirubin related test, then some other test, and test for the lastly the test for the possible blockage of the bile duct. Now, in enzymatic test, the most important is the ALT and the AST. As you very well know, what are these? These are the serum alanine aminotransferases and aspartate aminotransferases. Serum alanine, ALT, and AST means aspartate aminotransferases. These both enzymes are used to detect the hepatocellular injury. Actually, the liver damage, there are two things in this. First, that is the hepatocellular injury, and second is the cholestasis, means impaction, or you can say there is blockage of the bile duct. So both these conditions, there are these two conditions that are judged by some tests are there that can judge both the condition, and some are specific for the cholestasis. So both the tests, these are the AST and the LT, these both enzymes are used to detect the hepatocellular injury. These both alanine and the aspartate, these are involved in the formation of glutamate from the alanine and the aspartate. These enzymes play important role in gluconeogenesis and the formation of urea. The ALT is a cytoplasmic enzyme found mainly in the hepatocyte. So it is a special test for the liver cells, or you can say specific for liver. Hepatic ALT activity is high in dog, cat, and humans. Hence, it is used to measure hepatocellular injuries in these species. Hepatic ALT activity is low in horses, cattle, sheep, and swine, and in these species not used routinely to assess the hepatic injury. Here I want to mention one thing: in most of the thesis or most of the research work, We have found that the cattle, sheep, and in horses, we have also, मतलब जब सब करते हैं, टेस्ट करते हैं, we are putting our sample in an auto analyzer, कोई बात नहीं, ALT भी आ रहा है, AST आ रहा है, but remember this thing that ALT is not a validated test in case of horses, cattle, sheep, and swine. So this should not be used. You can use the AST, but not ALT in these species to judge or assess the hepatocellular injury. Next is the AST, or the aspartate aminotransferase. It is a cytoplasmic as well as a mitochondrial enzyme. It is found in the hepatocytes and the other cells also. Here it is important that it is enzyme of the hepatic cells as well as the other cells. The irreversible or the reversible and the irreversible damage of the liver cell causes the release of the cytoplasmic AST, whereas the irreversible damage to the cell will cause release of mitochondrial AST. Here, I want to say that whether it comes from the liver or the another cell, whether it comes from the cytoplasm or the mitochondria, we only measure the serum AST. We are not measuring the source of AST. So AST alone is not a validated test for the liver. For liver function test, say for example, if AST is high, then we should go for another test. For example, if we are expecting that AST may be high due to the possible muscle damage, or then we can go for the CK test, creatine kinase test. Or so actually we got the hepatic profile. Not only our conclusion is based on one enzymatic test, rather we got the hepatic profile to draw a conclusion from the test. So here the AST that will be found elevated or it is not in the reference range, then we should take into consideration many factors. First, that source is not the liver itself. There might be another tissues that we may have got injury and they are releasing the AST. So routine biochemistry tests are not able to distinguish between these two sources of the AST. The activity of AST is high in liver of all domestic animal species, and it is routinely used to test the hepatic injury. But the AST activity is also high in muscle, kidney, pancreas, and erythrocyte, and serum activity is likely to increase when the cells of these tissues are damaged. There is no single specific test for determining the origin of increased AST activity. So that was all about the AST and the ALT test. Now the AST, regarding the values of the ALT, there are wide variations. Like ALT that has been measured in dog by the different researchers, it is activity has been measured in international unit as 0 to 18. So there are many more reference ranges. So before arising to the conclusion, you should go for reference range and also the age and status of the animal. Next enzyme is the sorbitol dehydrogenase, also known as erythritol dehydrogenase. It is a cytosolic zinc metalloenzyme. It converts sorbitol into fructose using NAD as a cofactor. It is predominantly present in liver and only small amount is detected in other tissues. So it is unique for the hepatic cell injuries. It is useful in assessment of the hepatic functions in large domestic animals, including dog and horse. It has a short half-life and activity is labile. So immediately after drawing the sample, you should go for this test. For example, if you are you have to test many, you have a sample and you want to go for many tests, so you should preferably do as sorbitol dehydrogenase test at first, because the activity will decline with time. Next enzyme is the arginase. It is important enzyme of urea cycle and convert arginine into urea and the ornithine. This enzyme is present in two forms, arginase 1 and arginase 2. Arginase 1 is cytosolic and it is mainly present in the kidney. And in kidney, its main role is in urea synthesis, whereas arginase 2 is present in mitochondria. It is mitochondrial and it present in most of the tissues, including the kidney, Its role plays key role in synthesis of ornithine, and it controls the availability of arginine for nitric oxide synthesis, and it helps in decrease the blood pressure, as nitric oxide has a role in vasodilatation. The activity of arginase in liver is higher than the other organs, so it is validated for measurement of the hepatic activity, as the sorbitol dehydrogenase and AST. This is also validated for the measurement of the hepatic activity. The sustained elevation in this activity is indicative of unfavorable prognosis. That is very much important, means there is injury that is not repairable, or the regenerating power of the hepatocyte has been lost. It is a convenient assay and useful for dog, cattle, sheep, goat, and horses. Next important enzyme is the GD, or the glutamate dehydrogenase. It is useful for all ruminants and dogs, and it is found primarily in liver, kidney, cardiac muscle, with lower levels in brain, skeletal muscles, and leukocytes. It is located in mitochondrial matrix and catalyzes the oxidative deamination of glutamate to form alpha-ketoglutarate and ammonia. GD catalyzes the reversible conversion of glutamate to alpha-ketoglutarate and ammonia while reducing the NAD to NADPH. Here you can see this reaction that it goes in both the direction, or it is a reversible direction, reversible reaction. Now there is formation of, from glutamate, there is formation of alpha-ketoglutarate with simultaneous production of the ammonia. Here the ammonium ion is shown, actually ammonia that can easily deliver the ammonia. Now if there is excess of ammonia in body, or there are more production of ammonia, then this ammonia will combine with the alpha-ketoglutarate and there is formation of glutamate. Okay, you can study. So you can very well understand by this reaction. So it prevents the toxicity that may be caused due to excess amount of ammonia. Or you can see that this is important enzyme for both anabolic and catabolic reaction. How anabolism is taking place? Because there is formation of glutamate or glutamic acid from the it can be formed. So it is a catabolic as well as an anabolic reaction depending upon the substrates that are available. So elevated activity is associated with the bile duct obstruction and the necrosis. The another important enzyme is the ornithine carbamyl transferase, or OTC. This enzyme is present in mitochondria, and it also functions as a part of the urea cycle, like as previous enzyme. It is useful test for all ruminants and pigs. Another important enzyme is the alkaline phosphatase. It is a membrane-bound glycoprotein. Here it is a membrane-bound glycoprotein, so it plays an important role in the transportation or the phosphate group across the membrane. It is a zinc metalloenzyme, and alkaline phosphatase is divided into 4 isoenzymes. Isoenzyme means having the similar function, but they have some structural differences. So there are 4 isoenzymes of the alkaline phosphatase depending upon the site of tissue expression, that are the intestinal alkaline phosphatase, then placental alkaline phosphatase, then germ cell alkaline phosphatase, and tissue non-specific alkaline phosphatase, or that is present in the liver, bone, and the kidney alkaline phosphatase. The alkaline phosphatase catalyzes the hydrolysis of phosphate monoesters at basic pH levels, and high concentrations are found in intestine, kidney, liver, and bone. Alkaline phosphatase activity is very useful serum biochemical indicator of liver disease, particularly in cholestatic diseases. Increase in this activity of alkaline phosphatase in serum and other body fluids may reflect the physiologic or pathologic changes that are not of hepatic origin. Actually, alkaline phosphatase, it is important for a hepatic test, and also mainly it reflects the bone condition also. And its increased activity is suggestive not only of any pathological condition, but it may increase in some physiological condition also. So reference age should also tally with that of the mostly because the reference age are given of the adult animal. So to draw a conclusion, the age, the sex of the animal, that should also be taken into consideration, because certain condition like the pregnancy or the lactating animal or the young animal, or that there is therapy with certain drugs like corticosteroids, all these causes increase in the level of alkaline phosphatase activity. So non-hepatic increase in the alkaline phosphatase activity is observed in the young animals, in pregnant and lactating females, and in association with the high fat diet. A non-hepatic increase in serum alkaline phosphatase activity is also observed in bone diseases, endocrine diseases, neoplasia, and by certain drugs such as glucocorticoids and anticonvulsants. In normal animals, the alkaline phosphatase of serum originates primarily from liver and bone. Mainly the sources, we are measuring the serum alkaline phosphatase. So its source is the liver and the bone. The increased activity is observed in following pathological condition, that is the acute and the chronic liver diseases, cholangitis, cholestasis, biliary cirrhosis, and the extrahepatic bile duct secretion. One important landmark about this alkaline phosphatase activity that the biliary secretion contains a large amount of the alkaline phosphatase enzyme. Remember that biliary secretion contains a large amount of the alkaline phosphatase enzyme. In case of the obstruction of bile flow, there is de novo synthesis of alkaline phosphatase, and the newly synthesized alkaline phosphatase is poured into the circulation. And regenerating liver also synthesize increased amount of alkaline phosphatase. The enzyme, as we talked earlier, like the AST, ALT, they indicated the hepatocellular injury, means when there is any insult to the hepatic cells, then there is release of the, there is breakdown of the membrane of the hepatocytes, and these enzymes are released into the plasma. But here you can see that when there is hepatic insult, then there is increased secretion of this enzyme, and it is not released by the cells, but it is actually, its level is increased due to the increased synthesis of this enzyme. This test is useful in assessment of the cholestasis in horses, dog, and cats, and less valuable in cattle and sheep because of wide fluctuations in normal alkaline phosphatase activity. And here comes the GGT, which is also a very much important and sensitive marker of the hepatic function test. And in human, you may be knowing that this test is used for the chronic drinkers, or you can say that even if someone has started, then GGT level will immediately shoot up in those individuals. So in animals also, this has got importance, although there are physiological variations are also great in this, as in case of we have seen the AP, the GGT is also high in case of the pregnant, lactating, and the animals that are having high vigorous physical activities. So in GGT is primarily associated with microsomal membranes of the biliary epithelium. It is also present in canalicular surfaces of the hepatocytes, pancreas, kidney, and other. Some consider GGT to be the single test for highest sensitivity of liver diseases in large adult animals. Increase of GGT is most pronounced with obstructive biliary disease. It indicates both the hepatocellular injury as well as the obstruction of the biliary duct. In acute hepatitis, hepatic diseases in horses, the GGT may continue to increase for 7 to 14 days despite of the clinical improvement. That is also important, that its value doesn't come to the normal easily. The chronic hepatic fibrosis is the only liver disease in which the abnormal increase in GGT might not be seen. So in chronic cases, when we are seeing the physical symptom or the things that are reflecting any liver damage, then GGT, if it is a chronic condition, then we cannot rely on this GGT test. the neonatal foals have higher GGT concentration due to GGT present in the colostrum and the milk. The horses, those in active training, may show a non-specific increase in GGT that is not associated with the liver disease. That is also important because there are as I told you, that there are some physiological variations also in alkaline phosphatase as well as in GGT. GGT is of little value in diagnosing liver diseases in neonatal calves or lambs because it is present in colostrum and milk. So in horses, calves, and lambs, all we cannot rely on this because there is physiological increase. The GGT activity may also be increased with administration of certain drugs like rifampin, corticosteroids, benzimidazoles, and helminthics. And to draw a conclusion, the reference range must be appropriate for the species and age group being evaluated. Now, the interpretation of the liver enzyme elevations means, as we have seen, that from 0 to 80, 0 to 220 international unit, these are the values for many of the enzymes that are reported by the various scientists. So how we can interpret the result? There is great variation or wide range. So under these, we can have a mean value, and the mild increase means there is 2 to 3-fold elevation in the enzyme activity that comes under the mild, and moderate means when there is 5 to 10-fold elevation in the activity of the enzyme, and marked increase is said when there is 10-fold increase in the enzyme activity. And another important, first was the enzymatic test, and another is the most important is the bilirubin test. And its related test that the first year students also have gone through these tests in urine analysis, and we will have a great elaborative discussion on these tests, because the enzymatic tests that are generally in automated machine, and we are more related with only the result rather than their procedures. Now, regarding the bilirubin test, this bilirubin is a yellow pigment that is made during the normal breakdown of the red blood cell, as we all know. The bilirubin test measures the level of bilirubin in serum sample, which may be conjugated or non-conjugated component. Important indication of LFT is jaundice. The cause of high bilirubin may be prehepatic, hepatic, and posthepatic. That we will understand by the next diagram. And once you understand this diagram, you will never forget in your future about this, what is prehepatic, what is conjugated, what is unconjugated, and which will raise in which type of the disease. So first is the prehepatic. It means, as the name suggests, means before the liver. It occurs due to excessive breakdown of the RBC, or in case of hemolysis, it is observed. In such condition, the unconjugated or indirect component is increased. In case of hepatic, the cause of jaundice lies within the liver. In this, both the direct and indirect component is increased. Hence, it gives the biphasic Vandenberg reaction. And post-hepatic, it occurs due to the obstruction of the bile duct, or we can say the obstructive jaundice, and there is increase in the direct or the conjugated fraction of the bilirubin. Now, what is conjugated, non-conjugated, or unconjugated? How this you can see this diagram very carefully. Here is the blood vessel, and there is a reticuloendothelial cell where the breakdown of the red blood cells occur. Now, with the breakdown of the red blood cell, there is release of the bilirubin. This bilirubin will enter. Now, it is free bilirubin, or you can say that is not conjugated with any other thing. So, it is known as the unconjugated or indirect fraction. So, by the breakdown of the red blood cell, there is unconjugated or indirect fraction that is formed. It will reach to the liver, and in liver, it is joined, or it is glucuronization of this bilirubin occurs, or it is conjugated with the glucuronide, and there is formation of bilirubin diglucuronide. Okay. And what is this conjugation means? This conjugation means increasing the solubility of this bilirubin so it can be excreted. Now in liver, it is conjugated with glucuronide, and by the portal and by the bile duct, it is carried to the intestine. In intestine, it is degraded, or bacterial reduction takes place, and it is converted into urobilinogen or stercobilinogen. And stercobilinogen is further degraded into stercobilin, which imparts the color to the feces. And this urobilinogen from the portal vein reaches back to the liver, and from liver to the general circulation. From general circulation, it reaches to the kidneys, and from kidneys, it is excreted in the urine in the form of urobilinogen, and which is responsible for the pale color of the urine. So now you can very well understand what is direct, indirect, or the conjugated, unconjugated, and in which type of, if there is, you can say, when there is excessive breakdown of the RBC, then which fraction will be increased? It means unconjugated or indirect fraction will be increased, because there might not be sufficient glucuronide to conjugate whole of the bilirubin that has been formed. If there is obstruction of the bile duct, then this conjugated bilirubin will not able to pass into the intestine. Okay, then, and furthermore, there will be the injury of the hepatocyte. Then under this condition, both the direct and indirect component will be increased. So this is the key diagram to for the basic understanding regarding the conjugated and unconjugated fraction and what will be the impact on the hepatic cell. The serum bilirubin is detected by the diazo reaction. The bilirubin, I will repeat this because this is very much important for UG students to understand. The serum bilirubin is detected by the diazo reaction. The bilirubin is reacted with the diazotized sulfonylic acid, and it gives the azobilirubin, which is pinkish purple in color. Bilirubin, it reacts with diazotized sulfonylic acid, and there is formation of the azobilirubin, which gives pinkish purple color to the solution. The conjugated bilirubin gives immediate reaction. Conjugation, as I told you, but does it mean? It means the increasing the solubility. Okay, so whenever there is conjugated bilirubin means that has reached to the liver and it is conjugated with glucuronic acid. So the conjugated bilirubin gives the immediate reaction, or we can say the direct reaction. Whereas the unconjugated bilirubin requires a solubilizer. That solubilizer may be the methanol or the ethanol, and color appears after 30 minutes. So it is known as the indirect reaction. When the color appears late, then we will call that it gives the indirect reaction. In case of the hepatic jaundice, the reaction is biphasic, which means that color develops immediately and the intensity of the color is increased after some time on addition of the methanol or the ethanol. That's why this is known as the biphasic reaction. Means initially color will develop, and on addition of the solubilizer, the intensity of the color will be increased. Okay. Now, the test for the bile pigments. The test for the bile pigment in urine is Fauci test. That usually the UG student you might have done in your practical classes. The test for this bile pigment, it is by the Fauci test. It is positive in case of the hepatic and the obstructive cause of jaundice, while it is negative for the hemolytic or the unconjugated form of the bilirubin. Here you can see that it is a round yellow one. It is the precipitate on the filter paper, and when we will add the drop of Fauci reagent on this wet filter paper, then it imparts a blue-green color, which is due to the oxidation process, And the procedure for this is that we will take nearly 10 ml of the urine sample and we will add 1 gram of the barium chloride. Actually, what will happen, there is formation of the barium sulfate. This barium sulfate, when we will filter this barium sulfate will remain on the filter paper, or it is having high molecular size, so it will remain on the filter paper, and we will spread out the filter paper. Now this bile pigment, they will attach to this barium sulfate, and then on the wet filter paper, if we add the Fauci reagent, then this bile pigments, they will impart to the blue-green color. So that indicates the presence of bilirubin in urine. So this is known as very much important test, and it is known as the Fauci test. It contains, the reagent contains the ferric chloride and the TCA. And another important test is the Melin test. You can see various color develop in this. For this, you will take the concentrated nitric acid in a test tube and slowly place the equal quantity of the urine over it. The tube is shaken gently, and depending upon the amount of the bilirubin, different colors we can observe, that it may be the yellow, red, violet, blue, or the green. So different play of color will be observed within 10 minutes. So these are both the tests that are usually performed in veterinary hematology, biochemical test, and most of the students, you have done this test. Another important test or liver function test is bile test for the bile salt. So as we know, bile function of the bile salt, they decreases the surface tension. Surface tension. So test for bile salt in urine is Hayes test. It is positive in case of hepatic and obstructive jaundice, while it is negative for the hemolytic or unconjugated form of bilirubin. This test is very much simple. As you can see in the diagram, there are 2 test tubes. In one test tube, you can simply take the water and sprinkle some amount of the sulfur powder. This sulfur powder is yellow in color, you can see, and it will be present on the surface only in case of water. Whereas if bile salts are present in another test tube, you can see, if bile salt are present in the sample, when you sprinkle the sulfur powder over this, then it will sink or come at the bottom. If it comes at the bottom, it means that bile salts are present, because it decreases the surface tension and bile salts are not able to remain over the surface, and they will ultimately come to the surface of this test tube. So it is very simple, and very good results are seen in case of this test. Another important test is the test for the urobilinogen. The presence of urobilinogen the presence of urobilinogen in urine is indicative of the hemolytic jaundice. In this, what we do generally, take 5 ml of the urine and add 0.5 ml of the Ehrlich reagent, and you will observe a pink color. And if the content of urobilinogen is high, then the dark color or pinkish to red color is observed, and that is the positive test for the urobilinogen. So these are the various tests that are related with the bilirubin. Then another important function test or LFT is the proteins. As we know that the liver has a synthetic function, it synthesizes the proteins. The liver is the exclusive site for the synthesis of the plasma protein albumin. It is exclusively synthesized by the liver. So if there is damage to the liver or hepatocellular injury, then there will be increase in serum albumin, and the condition is known as the hypoalbuminemia. And simultaneously, the globulin fraction will also decrease, but only the As we know that there are alpha, beta, and gamma. The gamma globulin, these are synthesized by the plasma cells, and alpha and beta component are synthesized by the liver. So albumin will decrease and alpha and beta globulin fraction will be decreased. But actually what happens, the gamma globulin fraction is increased. So there is decrease in the AG ratio. That is very much important. Although the albumin level increased and the alpha and beta globulin level increased, but the gamma globulin level increased so much that the AG ratio is decreased in this condition. So the albumin synthesis is very much important, and as we know that is important for maintenance of the oncotic pressure, and it is very much important transporter also. And unlike most of the plasma protein, which are glycoprotein, albumin contains no carbohydrate moiety in that. So the functions that are related with the albumin means maintenance of the blood colloidal osmotic pressure and transportation, that all will be affected when there is injury to the liver cell. And another important test, LFT, is the protein C. Protein C is an anticoagulant protein produced by the liver cell. The measurement of the protein C provide information regarding the liver function and the perfusion or the blood supply to the liver. Then comes the serum ferritin level or serum. The ferritin represents the iron stores in the liver. It decreases in anemia and increases in hemocytosis and hemochromatosis. Now, what is this hemocytosis? It means the focal deposition of the iron. So when there is excessive breakdown of the RBC, another component are managed. And what about the iron? Iron will be stored in the body, or there will be different organs, there will be focal deposition, and it is not much condition to worry about. But hemochromatosis is a condition that requires the attention, because there is excessive deposition of the iron, and these irons sometimes may excreted by the kidneys in such a way that the tubules get blocked. So it is important. So hemochromatosis, it is the condition then which there is excessive deposition of the iron in the tissues. So that serum ferritin level, we have at our Raju we generally for PG student we got about these tests, like serum iron. For the serum iron content, dipyral method is generally used, and UG teaching we are generally not related with these levels. Next comes the globulin levels. The alpha and beta globulins are synthesized by the liver, whereas the gamma globulins are synthesized by the plasma cells, as I told you earlier. In case of the chronic liver diseases, the globulin fraction increases, hence the AG ratio is changed. Then comes the immunoglobulin. As we know that in case of the injury, the IgA, IgG, and IgM will be increased. In case of acute insult, IgM will be increased, but if this is a chronic disease, then we will find IgG fraction has been increased. Then HBsAg or hepatitis B surface antigen. This test is done only in case of the human beings and chimpanzees, but not in domestic animal. But for reference merely, I have written this in your presentation. That is the important liver function test of human beings. That is the HBsAg, means hepatitis B surface antigen. Then comes the sulfobromethylene test, BSP test, also known as the bromosulfethylene test or indocyanine green. This is a dye that is used to judge or assess the hepatic functions. This dye is used for functional capacity of the liver and also for the hepatic blood flow. Following injection, these dyes are rapidly removed from the plasma, mainly by the liver, and excreted in bile. Actually, what happens, a single dose of these dyes is given, means injected, is dissolved in water and or NSS, and these are injected. And after within 15 minutes, we will take 3 samples of the plasma and see how much fraction is present in the plasma, how much clearance of the plasma is there. So after a single injection, we will take 3 or 4 subsequent sample. So these are 2 dyes actually, the BSP and the indocyanine green. Indocyanine green that is available commercially also, and BSP is a little bit irritant, and if it is leaked, it will cause irritation, and we can give only under in those patients that have normal cardiac functions. If the cardiac functions are compromised, then this dye is not indicated or validated for hepatic function test. The normal clearance half-life of BSP in different animals is different. So it is less than 3.7 minutes in horses, 2.13 in goats, and less than 4 minutes in sheep. BSP clearance in lower in calves than in adult cattle. So this should be taken into consideration. And then comes the prothrombin time. My previous speaker has given a detail about this prothrombin time. That was very good and informative. Actually, this prothrombin, second number clotting factor, is synthesized by the liver, and it is synthesis is dependent upon the vitamin K. So in case of the obstruction or in case of obstructive jaundice, when the absorption of the vitamin K is hampered, then the synthesis of this clotting factors is also hampered. So prothrombin time is generally done in case of the before surgery also, like BT-CT. This prothrombin time is also done to assess the liver functions. Then comes the liver biopsy. Liver biopsy, what does it mean? Means the taking the sample from the live animal is the biopsy technique. So first, actually, what are the steps? First, there is any clinical history, then we will go for clinical examination of the animal. Then we will perform some biochemical test. We will get a hepatic profile. And if the hepatic profile is suggestive of any neoplasm or any tumor in case of the liver, then we prefer for the liver biopsy. So it is actually to confirm our cases, what we are thinking. So liver biopsy is a definitive way to diagnose the hepatic disease if imaging test shows a tumor in the bile duct. So there are different type of the biopsy. Here we will discuss in detail in next few slide. Here I will only read out the name of these slide. These biopsies during cholangiography, that is the ERCP or PTC, that is the endoscopic retrograde cholangiopancreatography, and the percutaneous cholangiopancreatography is being done. Then we can take the sample, and during cholangioscopy we can take the sample, and when we are doing the ERCP, then we can also have the needle biopsy. Now these we will go into detail in imaging test. Actually, the imaging test uses the X-rays, magnetic field, or sound waves to create the picture of the inside of the body. In imaging test, first is the ultrasounds. Then ultrasound uses the sound waves and their echoes to create images of the inside of the body. A small instrument called the transducer that gives off the sound waves and picks up the echoes as they bounce off the organs inside the body. The echoes are converted by computer to an image on the screen. In this, first is the CT scan or computed tomography. The CT scan uses X-rays to make detailed cross-sectional images of the body. Now, what is this cross-sectional images of the body? As you eat the tomatoes in salad, you make the sections of this like those, or you can make the slides in case of pathology, histopathology. You can make that tubes and then go for section cutting like those. These we got the different cross-sectional areas of the body, and by this we can also have the depth of any tumor or any obstruction in case of the bile duct. So mostly CT is for hard tissue and MRI is done for soft tissues. So CT scan uses the X-rays to make detailed cross-sectional images of the body, and it is used to diagnose the bile duct cancer by showing the tumors in the area. Actually, these are the advanced tests and mostly used in case of mostly used at Tanuas and Gadwasu. And CT scan is also present at our institute also, but we have limited use of this scans in our animals. And this CT scan also help to diagnose the stage of the cancer or the organs near the bile duct, especially the liver and the lymph nodes, how much cancer has been spread and to which extent it has affected the various tissues. Then CT angiography can be used to look at the blood vessel around the bile ducts, and CT guided needle biopsy. Biopsy needle through the skin towards the suspected mass. We can have a small needle by all aseptic precaution. We directly make a prick over the screen, and we will take the or suck up the fluid or the cells that are present, and we can have the sample for the biopsy. A small amount of the tissue or sample is taken out through the needle for the laboratory test. Then comes the MRI. These are the advanced techniques. The MRI scans show the detailed image of the soft tissue in the body. The MRI scans uses the radio waves and strong magnetic field instead of the X-rays. Here, a contrast material called the gadolinium may be injected into the vein before the scan to be detailed better. Because when we use a contrast material, it gives the, say for example, it is a biliary duct. So it will line the duct and we are able how much far it go. If there is any obstruction, this contrast material will not able to pass through that. Sometimes they can help to tell a benign or the non-cancerous tumor from that of a cancerous tumor. So cholangiogram, what is cholangiography? And by the cholangiography, we receive the cholangiogram. Now, what is the cholangiogram? It is just like as we say that echocardiogram or echocardiography is procedure and the result. So the cholangiogram is an imaging test that looks at the bile ducts to see if they are blocked, narrowed, or dilated. It can also be used to help and plan the surgery. There are several types of the cholangiograms, each of which has different pros and cons. Now, the magnetic resonance cholangiopancreatography, also known as MRCP, or the endoscopic retrograde cholangiopancreatography, or the ERCP, and the percutaneous transhepatic cholangiography. First is the magnetic resonance cholangiopancreatography, or MRCP. The images in this, the images of the bile ducts are obtained with the same type of the machine used for standard MRIs. Neither an endoscope or an IV contrast agent is used, unlike that of the another cholangiogram. If you have some problem and you might have gone for some USG, then you have or MRI, you can see that there is a transducer that is placed over the skin, and a picture of that particular organ is available on the computer screen. So it is a non-invasive test. That is the important aspect of this. And this test cannot be used to get the biopsy material or tumor, or to place stents or a small tube in the duct to keep them open, because it is a non-invasive test. Simply place the transducer over the site, and no contrast agent is used, because for contrast agent you have to give it through the endoscope, or you can give it through the different method by. So it is simply the method of visualizing the internal structure. Then comes the endoscopic retrograde cholangiopancreatography, or the ERCP. It is in this, an endoscope is passed from mouth to the site. Site means at the entry of the bile duct, or you can place through from the mouth, then it will reach to the intestine, and then to the it is positioned towards the opening of the bile duct, and this process is done under sedation. And through this endoscope, a small catheter or tube is passed and at the end of endoscope and into the common bile duct. And with this, a contrast dye is injected through the catheter. The dye helps outline the bile duct and pancreatic duct as X-ray is taken. This image can show the narrowing or the blockage of these ducts. So a camera is also fitted at the end of this. This test is more invasive than MRCP and has the advantage to take the sample of the cells or the fluid for testing. ERCP can also be used to put a stent into the duct to help them keep open. Sometimes there is blockage of the bile duct that you simply place a stent, or you can make a pathway for the bile to reach at the intestine. So this technique is helpful. Then comes the percutaneous transhepatic cholangiography, that is the PTC. In this procedure, a thin hollow needle through the skin of the abdomen is inserted under sedation to the bile duct inside the liver. A local anesthetic is also used before putting the needle. A contrast dye is then injected through the needle and X-rays are taken as it passes through the bile duct. Like ERCP, this test can also be used to take the sample of the fluid or tissues and to put a stent on the bile duct, because this PTC is more invasive, so it is not commonly used unless the earlier procedures have failed, like ERCP. We can't do better than this, then we can go for this PTC, or this is the last choice for the hepatic function test. Then comes the scintigraphy. The biliary patency and the hepatocyte function, structure, and blood flow may be evaluated by the hepatobiliary scintigraphy. In this, the radionucleotide liver scans and biliary scans can detect the alteration in the blood or hepatic masses and biliary obstructions. Means hepatic perfusion you can detect, or cholestasis you can detect, any type of these hepatocellular injury you can detect, multiple uses of this test. The scintigraphy has been used in pig, foals, and lambs to differentiate biliary obstruction from the other causes of the hyperbilirubinemia. But nowadays, this test is not being used because radionucleotide substances are used in this test. And lastly, the conclusive is that regarding the liver function test, that the tests related with the liver function in laboratory are important for evaluation and monitoring of the clinical patient with liver diseases. Actually, these tests can be performed on the clinical cases, as well as in non-clinical cases. Means you can perform laboratory test for the screening of the animal. Screening is essential in those cases when we found that there are chances of injury or chances of liver diseases. For example, exposure to the infectious agent that cause hepatitis, or there is familial histories or inherited disease, then we can go for the screening by this laboratory test. And in case of the clinical cases, these tests help to diagnose, or you can say that to estimation of the severity of the infection, or the progression of the disease, or the prognosis of the disease, that all these tests will be helpful to judge this. So these tests are done to find out the integrity of the hepatocyte. As I told you, that AST, ALT, and SDH, these are increased in case of the hepatocellular damage. So integrity of the hepatocytes is affected. And to judge the status of the biliary system, biliary system for this AP, GGT, and GD are important. And to judge the excretory capacity, that means the bilirubin, bile acid, ammonia, and to also judge the synthetic capacity, the albumin, prothrombin, because it has more of very much versatile function. So different aspects are reflected in case of this laboratory test. And most important is the interpretation of this test. The interpretation of this test must be based on the age, sex, and the physiological status of the, and particularly the species also. In which species, which test is appropriate. As I told you that ALT is not validated for ruminants, small ruminant in case of the cattle, sheep, goat. We should not use these tests as these standard books doesn't validate these tests for in this species. And in most of the cases, we got the hepatic profile rather than a single test. Generally, these are carried out by automatic machines. So we will found 5, 6, 10 tests in a series of the tests that is known as the hepatic profile. So that help to arrive at a conclusion. And by the hepatic profile, if we are able to diagnose that there is any stasis or any neoplasm or any another thing that is not able to rectified by the treatment, then we can go for the hematic imaging and the liver biopsy, or you can go for these advanced techniques. So that was all about this our liver function test. Hope you enjoyed this test, or although the topic I found this is exhaustive, and for first year students and for UG students, little bit more, and only the, I think urine analysis in their course is mainly involved.
Thank you, madam.
Okay, sir.
Nice presentation, good informative. Now topic open for discussion.
I request to online as well as the offline participant to please raise your query if you have.
Dr. Sunita, good afternoon. How are you?
Fine, sir. Fine, sir. I listened, sir. Your lecture was very much informative, and I would like to always in contact with you for further information regarding the blood transfusion in small animals.
Yeah, sure, madam. Thanks a lot. Your lecture was very nice, wonderful. I'm sorry that I kept you waiting so long.
No, sir. Nothing. I got information from you, sir. Keep on going. This is our job profile, sir. Sharing and getting the information. Yes, sir.
Could you throw some light on LDH levels, lactic dehydrogenase?
Sir, lactate dehydrogenase level in which species? Species wise, sir. Lactate dehydrogenase, it is also validated for, sir, in all the animals, actually small animal and large animals also. And I do not remember the levels, sir, not of all, because we are dealing with a great number of the species, and yeah, I have written, sir, some. So I have written some values, sir, but for LDH I have no values at present, but I have done my research work, and in that thesis I have the values, sir. At present I am not able to tell you about the exact values. I have done this in case of the superimposed stressor in sheep also, sir, LDH level.
When would the values increase? That's what I want to know. I don't want to know any exact values. Under what conditions would the value increase?
Hepatic injury, sir, when we are getting an hepatic injury, sir, actually the level increased in under my study, it was increased in superimposed stressor that included the transportation stressor and the ambience stress, and also the regrouping stress, that its level was increased.
Okay.
Sir, I will give you personally the detail of that study if you are interested, that I will give you about the levels of increase and how much, what was the findings of that study. I have carried out in my doctoral research at that levels. Okay, sir.
Thanks. Thank you very much.
Any other participant? From first year students? Any other participant who wish to raise his or her query? I think no one. Madam, I am very thankful to you for your presentation. And this liver function test are very vital test for the analysis of the normal body condition also.
Okay, thank you very much, madam, for a nice presentation.
Thank you, sir. Thank you, sir.
Now the topic is open
for last 5 minutes, but students are coming. Please wait. Please, have a seat.
For hepatitis, Madam.
Yeah.
I have one question. Particularly hepatitis in canine. Which case is better, in GGT or AST, madam? In canine, particularly when hepatitis are occur,
GGT, it will give the hepatitis as well as the obstruction of the bile duct, that also can. And you in canines, ALT is most important. You can go for ALT.
If there is a heart problem in canine, okay, that time also the GGT level may be sometimes raised. If possible?
No, GGT is mainly for it is for hepatocellular injury and as well as for cholestasis, and it is exclusively, or you can say, sensitive marker for liver only. As we know that ALT is also present in many cells, AST is also present in many cells, but for canine you can go for ALT as well as for GGT.
When many liver injury are occur in animal, so that is the one type of the stress of physiology in that particular liver damage. So any kind of other test we carry out, the oxidative stress test we can measure along for the ALT or AST case.
Ma'am, please, I'm not getting your question.
When liver damage occur, particularly considering large animal.
Yeah, large animal.
So physiological factor for liver damage consideration, it is due to the oxidative stress.
Yeah,
so,
yeah.
Which is the in that oxidative stress condition in large animal? We prefer for that.
Oxidative stress, you are asking about the oxidative stress and functions of the liver marker. You are.
नहीं मैडम, मेरा क्वेश्चन यही है कि लिवर टेस्ट तो हम करते ही है, बट ऑक्सीडेटिव स्ट्रेस के लिए कोई एंजाइम का टेस्ट आप बता सकते हैं कि वो हम करेंगे along with the liver test?
Yeah, catalase है, बहुत सारे एंजाइम है, MAO है, वो करते हैं हम. 5' न्यूक्लियोटाइडेज लीवर के लिए भी है, स्ट्रेस में भी ये एंजाइम. GGT is also considered for a marker of the oxidative stress, oxidase, peroxidase, that all we can carry out. These are also the stress markers. Besides the liver function test, GGT is also a sensitive indicator of oxidative stress.
Madam, among the SOD enzyme and
SOD catalase, you can go for that.
Which one is better for liver injury?
For
my knowledge, SOD and catalase. For which one test is better? For particularly only for liver damage.
SOD and catalase. Actually, SOD is mainly for metabolic, that is for SOD is mainly for the oxidative stress, ma'am. SOD mainly oxidative stress. Actually, first SOD will function. It will remove the superoxide radical, and there is formation of H2O2, and then only the catalase will come on the second line, and it will work in conjunction with the SOD. It will work in conjunction with the SOD. So SOD will not eliminate all the radical. It will bring the superoxide radical to the H2O2 level, and then only the catalase will react, and it will ultimately bring this H2O2 into the water and oxygen level.
And one last question. In case of the fatty liver syndrome, one of the most important metabolic disease in cattle, particularly exotic breed of the cattle. So that is the rise of the particular that AST level. We find out the higher level of the AST along with the nephron. In fatty liver syndrome, then the AST level is one of the diagnostic indicator.
In cattle?
Cattle, fatty cow syndrome.
Yeah, madam, it is raised, as I told, many conditions you will find this level is increased.
Good afternoon. Good afternoon. Good afternoon, ma'am. My name is Odeda Subhas. I am first year BVC and A student, and my question is, ma'am, by which test we can differentiate between unconjugated bilirubin and conjugated bilirubin? By which test?
I have told you earlier, you can go for that Ehrlich test, or you can for that the Fauci's test that are for obstructive and that jaundice, different type of test. You have not seen the, again, I would like to share the screen. Urobilin, you can see that diazo test, you have gone through that test, means the bilirubin that will react with the diazotized sulfonalic acid. It gives, if it gives the immediate reaction, that it means conjugated. It means immediate reaction, it will give the purple color, that it means the conjugated fraction is there. But if the color appears after addition of the ethanol or the methanol, and color appears after 30 minutes, that it means that is the indirect test. It is positive.
Okay, ma'am. Thank you, ma'am.
Unconjugated portion is high.
Hello, ma'am. My name is Bhavani Kuldeep. I studied first year of Bachelor of Veterinary Science in Animal Husbandry. My question is, how liver tests are different in different animals?
How different liver test?
How liver tests are different in different animals?
Different in different animals.
Different animal species.
Different animal species.
Yeah, there are different indication. Yes, there are different indication for a different animal species. Enzymatic profile, metabolic machinery for different animal is different. That's why I told you that AST is not important in case of ALT is not important in case of ruminant, but you can go for AST. But AST is also present beside the liver. It is also present or expressed by the other tissues. So in conjunction with the other test or hepatic profile, you can go for a particular test. Like GGT है, ये आपके सब animals में मिलेगा, आपको small में भी मिलेगा, large में भी मिलेगा. So there are metabolic machinery is different. So enzymatic profile is different, and on the basis of that we have got this different diagnostic test for a particular species. So different tests are validated for different type of this species, or you can say for this species this test is good.
Hello, madam. Good afternoon. My name is Junagadh, and I am from CoVS and A.H student. And my question is, what the cholesterography effects on animal's intestine at the test?
Cholangiography, intestine.
Effect of cholangiography on the intestine.
Effect of cholangiography on the intestine.
while performing the cholangiography.
While
Is there any
perform-
adverse effect by performing
Yeah.
the cholangiography? If there is any
Yeah.
adverse effect on the intestine?
Actually, I have not performed these tests, but there might be reflex irritation as this is done under sedation when we are performing the cholangiography. There might be, as that in case of any sedative effect, one should be very cautious, or when we are inserting a tube inside the body, it should be properly guided and not to injure the mucosa of the intestine, and there might be I think there may be reflex vomition, or you should not the animal should not have consumed any liquid or solid at least 10 to 12 hours before this process is performed, so as to avoid any problem of regurgitation. And it is better to, as it is done in sedation, to pre-anesthetic agent to reduce the salivation, that also should be given to the animals.
Thank you.
So if there is no question, we conclude here.
Madam, I have one question. Sorry to interrupt, Chairman. I am PhD staff working here as a principal and dean of this college at Junagadh.
Good afternoon, sir.
I joined, good afternoon, bit late, but this topic is a very vital one.
Yes,
I usually image in the mindset of a human is that stress is always bad. It is considered as in a always negative way, but we consider in day-to-day life,
yes,
certain stress are essential. That is known as good stress.
yeah,
There are several events in our lifespan also. Though we know this is stressful, we always ready to undertake that stress. For example, becoming a father, becoming a mother, becoming a grandfather, becoming a grandmother, and so story endless. Though it
yes,
is
sir.
stressful, financially, mentally, physically, everything,
Yes, sir.
it is essential. It is considered as good stress.
Good stress, yes, sir.
Are there such phenomena in animal kingdom also where certain events in animals, especially physiologically, though it is stressful, it is considered as essential or good stress?
Sir, I have not, sir, validation, but on the basis of that we are working with the animals, with the pet animal and with the farm animal, that although when they are in group, they are feeling the stress, but if we keep them alone, then they are further in the stress. If they are in group, then there may be fighting for the feed and fodder. The bossy animal will get the more, and the animal which is weak will be on the backside. But if ample amount of food, then there is nothing to worry about. But if we keep on the basis of this, if we segregate all the animal, then I think that will not be able to for suitable growth of those animal, because they feel emotions also. So like us, they should be given minimum level of stress. And one thing more that I want to say, that the gradual exposure to the animal, to the novel experience, will help them to combat this type of the stressor. When this stressor is not any type of physical stress, or the level is not so much high. So if we increase gradual increase, if we gradually increase that stress level, then the animals are able to cope up those stress. I think that is more important, because as we know that transportation in animal is a stressor with well-known fact, and all over the country, all over in national or international, we are facing the transportation of the small and the large animal. But if we are conditioning the animals to that transportation, and if we simply put the animal in an cage and carry it toward the distance place, there is difference in the response of in between these two conditions. So by the conditioning, the stress response is also low, and they are able to cope up this stress. And a little bit of amount of stress is essential in animals, as we need in our life to progress.
Madam, usually it is observed that more comfort over a long run reduces the performance. Comfort is evaluated in the sense of stress. Without stress, performance will be diluted.
Essential. Yes, it is essential to a limited amount.
Yes.
Yes.
So, we should consider this is a physiological phenomena of stress. Those who are in comfort zone, suppose you are performing at Bikaner, and if you are transferred to Delhi Veterinary College, if suppose this is for example, there is no veterinary college at Delhi, your performance instantly will improve, but on a long run, it will not. So discomfort always improves the performance. Do you agree with this phenomena, or it is just for sake of saying in a literature that more discomfort, more performance? But there are certain examples that
individual perception is there.
Discomfort. Those who are living in a comfortable zone do not perform well. So actually, comfort and discomfort is comparatively the stress only. It is psychological, physiological, mental, financial, and others.
No, sir. Dilemma, great dilemma, sir. Sir, I was working as assistant professor in a remote place for a long period, and I feel there the conditions were different, and I think I have lost my 7 to 8 years of precious time that could I have that may be more fruitful for my professional life that I lost at that place. So, sir, that depends on many conditions, many circumstances. Can't say anything. That depends upon the personal interception and working place, and also your environment, actually.
Since last 20 years, you are in professional life. 7 years as veterinary officer and 13 years has been teaching.
Yeah, so among 13 years at 7th place, I was at the remote place at Navania Vallabhnagar.
Now it is high time to leave comfort zone and come to Junagadh once at least.
Okay, sir, call me, I will come. I will come, definitely, sir. Arun is my junior, and he was here at Bikaner College when I was on deputation in teaching also. And I would like to come at Gujarat. I like Gujarat. I came to Navsari College also.
We have many students from Rajasthan also under VCI quota.
Okay, sir.
Jammu, Kashmir and all. So we have better adaptability. They get acclimatized. Our Gujarat
culture is
the
same.
Junagadh, what we call, is having much simulating culture with the Rajasthan, especially South Rajasthan.
Yes, sir. Yes.
The Kutch district and Jamnagar districts are almost matching with Marwar.
Yes, sir.
People living lifestyle, especially the animal husbandry practices of small ruminants, camel, to some extent the buffalo breeding and all are almost matching. And many of our breeds are adapted well in Rajasthan also. And adjoining boundaries, many of the breeds of the Rajasthan are well adapted in Gujarat also.
Yes, humans are also well adapted. Humans are also well adapted. I have, sir, one TA from his pastor. He's graduated from Datiwada, Mohit Chen, and he has recently joined in January 2021 to our department. He's also from Gujarat.
Our Datiwada is almost Rajasthan only.
Yes, sir. At border, it is at border.
That place almost 30 years back in 86, 89 and all.
Okay.
People used to speak Marwadi and the tone of Rajasthani culture, and we also had that bati, dal bati. Rajasthan. We used to go on the border and, from Dhanera, many places. Our very destination of tourist, Abu is with you.
Yes.
But more Gujaratis are taking advantage of that geography. So, pay your visit occasionally as examiner, as a visitor.
Okay, definitely, sir. Definitely. I would like. love to.
advertising many posts. If you like to have leave your comfort zone, come to Junagadh.
Yes, sir. Yes, sir. Definitely, I would like. I would love to come. Okay, sir.
Thank you, madam, for sharing your views and making our faculty and the students more used to the stress, because stress is life and life is stress. It is synonyms, it seems.
Yes, sir. Yes, sir.
Thank you for supporting our movement of institutional development.
Thank you, sir.
Thank you, madam. Thank you for nice interaction. Lastly, with our dean sir also, and the students and faculties also. So we conclude here, dear participants, we conclude our this session here, and in the afternoon session, we will have the practical demonstration regarding the hematological functional test in the laboratories itself. So till then, goodbye to all the participants. Thank you.
Thank you, sir.
Good afternoon. To begin technical session 2 on day 4 vocational training on advancement in physiological function test in domestic animal and pets. We have Dr. Arun Sharma, Associate Professor and Head, Department of Veterinary Physiology, College of Veterinary Science and Animal Husbandry, JU Junagadh. He will present on hematological function test. So I request Dr. Arun Sharma to please continue with his presentation. Thank you, sir.
Madam, your voice is not coming properly. Shall I start?
Yes, sir. Yes, sir. You start.
Okay. Okay. So, very good afternoon to one and all. So today, for 5 days of one online vocational training on the advancements in physiological function test in domestic animals and pets. Today is the 4th day and the second session. Myself, Dr. A.K. Sharma, is going to deliver a practical session, and this particular session is devoted to only the hematological function test, and particularly the hematological tests we are routinely conducting in our laboratory. So with that, this particular demonstration session, already in morning session, Dr. Neenan Jacob is minutely touched all the topics of the hematology, including the theoretical aspects as well as few of the practical aspects. But my this topic is totally concentrated, focused on the physiological function test only. So before jump over to the different procedures, I would like to interact with the normal hematology. Like we all know that hematology, what is hematology, and we all know that this hemato means this is a 2 words combination, that is heme and ology. So hematology means related to the study of the blood and related to the blood components, and these components include the RBCs, WBCs, the platelets. These 3 components are considered as the hematocrit, or in general circulation, this hematocrit is known as the PCV packed cell volume. Other than the cellular component, there are different types of nutrients which are also present in the blood. So this hematology is covered the blood portion, study of the blood and its components. And why it is this hematological tests are essential. In nutshell, we can say that hematological tests are prognostic rather than the diagnostic. They are prognostic. Means prognosis means they can fall a picture, they can present a picture that something might be wrong in the body system. But exactly to pinpoint the disease, we need the other confirmatory test. So like the hematological test, we can diagnose like anemia. So anemia, there are different types of the anemia: sickle cell anemia, megaloblastic anemia, hypochromic, normocytic anemia, and likewise there are different kinds of the anemia. Can you hear my voice?
Yes. Yes, sir.
Okay.
Please continue.
So anemia, other infections. Infections means infection, particularly whenever our body get affected with any kind of the disease, the marker to indicate the disease is the increment of the WBCs. And there are different kinds of diseases where the different WBCs will be raised or decreased according to the disease condition. Hemophilia, this is also a type of the genetic disorder. Then blood clotting disorders and leukemia and other diseases, we can only prognose the disease. So this is a normal phenomenon of generation of different types of the blood cells. As we already know that there are RBCs, WBCs and platelets. These are the three blood corpuscles present in the blood in the general circulation. Among these RBC, if we name the single function of particular cell, like RBC, it is particularly used for the transportation of the respiratory gases and all the nutrients, particularly respiratory gases. And in respiratory gases, it is mainly used for the transportation of the oxygen. So this is the use of the main function of the RBC. When we talk about the WBCs, their main function is to defend the body against the foreign pathogens. This is the main function of the WBCs, and we when classify these WBCs, there are different kinds of the WBCs like granulocytes and agranulocytes. Granulocytes, these are three types. Neutrophils, this is known as the first line of defense. Eosinophils, particularly in the allergy and the parasitic infestation. Eosinophil count will be raised. Third one is the basophil. Then agranulocytes, these are the monocytes and the lymphocytes. So this hematopoiesis, particularly, hemato means blood cells, and poiesis, this suffix poiesis is means to origin, generate, development and maturation. So whenever we use this term hematopoiesis or the erythropoiesis, leukopoiesis, megakaryocytopoiesis, so it means that there is origin, development and maturation of blood cells. This is known as hematopoiesis. When we call the erythropoiesis, it means the origin, development and maturation of RBCs. So these RBCs particularly, they form in the fetal life, they form in the first trimester, they form in the yolk sac, then after that in the middle trimester, they form in the liver, and in the last trimester, spleen and the spleen portion is played a major role in the formation of RBCs. After the birth, since the birth to the before the maturation of puberty, the young one, all the long bones as well as the flat bones or membranous bones. The examples are very good examples of the flat bones are like the scapula, sternum, brain bones. These are all the flat bones or membranous bones. So all the part of the flat bones are involved in the formation of the blood, specifically RBCs. And in initial age of the living being, this long bone is also involved in the formation of the erythrocytes. But as the age advances, definitely all the flat bones are same, they perform their function for the erythropoiesis, but there is change, my dear students, there is change in the long bones. Their proximal and distal extremity is only involved in the formation of the RBCs in the adult stage, right? So this is the stage. These are the stages of the formation of the erythrocytes. Like this is the pluripotent hematopoietic stem cell. This stem cell is particularly self-renewable. It can convert into this PHSC, pluripotent hematopoietic stem cell. It can convert. It has an ability to convert either in RBC or WBCs or platelets or any other cells. That's why it is known as the stem cells. After that, when we provide the committed or specified nutrient to the PHSCs, they convert into the next conditions, that is the colony forming blastocytes. And these are this is number 1 for the, in case of the erythropoiesis, this is the colony forming unit, erythroid. And this converts into this is pro-erythroblast. Pro-erythroblast converts into early normoblast. Here, at this stage, the nucleus and the nucleoli are present. That's why it stains alkaline. And after that, this converts into the intermediate normoblast. This is the stage where the hemoglobin at this early normoblast, initial formation of the formation of the hemoglobin starts in the early normoblast, but it appears in the intermediate normoblast. That's why it is having the acidic as well as the alkaline stain. After that, late normoblast, and this last is the reticulocyte. Why it is called reticulocytes? Because here the remnants of the cell organelles are present over here. That's why it is known as the reticulocytes. So total 9 days period required for the formation of from proerythroblast to the erythrocyte. And out of the 9 days, only 7 days require these stages, means erythrocyte, to convert into the reticulocyte. And after formation of the reticulocyte, it takes 2 days to convert into the mature RBCs. And we all know that this mature RBCs is non-nucleated, right? And it is having the different shape in the different animal species, like camel in oval, then biconcave in horse, and the cattle in buffalo. So likewise, this is the megakaryocytosis. It forms the platelets. Then this is the leukopoiesis, where the 5 different types of the WBCs are formed. Now, when we come to the formation of, am I audible?
Yes.
Okay. Because here my monitor shows that you lost the internet connectivity. That's why.
No,
just check. Okay. So for performing any kind of the test, hematological test, we require the blood collection. For the blood collection, we need the test tubes, we need the needle, we need the swab, then the antiseptic or the spirit we need. But before, I think 5 to 10 years back, when we recall our memory, we used to perform the blood collection by using the simple glass tubes. Simple glass tube, we pour the suitable anticoagulant in it, and after collection of the blood, we plug the test tube with the cotton, and then performed our routine hematological analysis after reaching the laboratory. But nowadays, my dear friends, the situation is totally changed. There is one difference between so nowadays we are using the vacuum. Vacuum means they are having the definite volume. Up to that volume, we can collect the blood only. Then up to that level, the vacuum is created, and when we use the needle and plunger, which are properly meant for the collection of the blood sample by using the vacuum. So after applying the plunger and the needle into the suitable blood vessel part of the animals, there are different blood vessels involved in the collection of the blood sample, like buffalo, cattle, sheep, goat. We preferably use the site that is the jugular vein. In dogs, cats, we can use these femoral veins, and we can use the tail vein also. In cattle, buffalo, we collect the blood from the ear vein also. So for the collection of the blood samples, there are different kinds of the anticoagulated or the vacuum vials. we can identify easily the vacuole vials by the color of the cap of the vacuole. So there are different kinds of the vacuoles, but today's concern, like heparin vacuole, this is the heparin vacuole, which is having the green cap. Then fluoride and oxalate, like sodium fluoride, we can collect the blood sample for the blood glucose analysis. Why it is important? Because it hinders the glucose metabolism. It hinders by interfering in the glycolysis cycle, and it checks the enolase enzyme for further breakdown of the glucose. Like next is the EDTA. This is the choice of EDTA vials we are using in most of the hematological analysis. Ethylene diamine tetraacetic acid. Then this red color capped vial. This is a plain vial, or we can say that the coagulation clot activator vials. You can say this is the clot activator vial, which is particularly used for the collection of the serum samples. So these are the different kinds of the vials, and this is the ESR vial. This is particularly meant for the ESR estimation. So these are the different anticoagulated vacuoles. What is the advantage of the vacuole over the traditional glass tubes? The main advantage is we can collect the blood up to our requirements. Say for example, we need only 1 ml of the blood sample. But in the glass tubes, it is not possible that we collect only 1 ml. Maybe possible we can collect the 5 ml or 10 ml. So the excess wastage of this is the wastage of the blood samples. So to mitigate this problem, we use this vacuole, and this is very user friendly also. So there are different kinds of anticoagulants we are using. We all know that natural anticoagulant is the heparin, and the other synthetic anticoagulants we are using these EDTA, sodium chloride, sodium citrate, and ammonium oxalate, sodium citrate, like these. So after this collection of the blood sample, there are different routine hematological analysis we are routinely performing in our laboratory. So these are like hemoglobin test, hemoglobin concentration test. This complete blood count which we are including here in our first slot, these are performed only by manually. But nowadays, they can also perform automatically with the help of different automated small devices. Like number 1 is the hemoglobin concentration, then PAT cell volume, then erythrocyte sedimentation rate, ESR, then TEC, total erythrocyte count, then total leukocyte count, differential leukocyte count. This is interesting. Why it is not it is mentioned as the differential, not the different leukocyte count? Because differential means they all are WBCs, but we can differentiate. We can differentiate all the WBCs by their characteristic different parameters they are having. Like we can differentiate the WBCs according to the presence or absence of the granules. Presence of granules means granulocytes. They are neutrophils, basophil and eosinophils. All three are the WBCs, but we can differentiate. We can differentiate on the basis of the presence or absence of the granules, and we can further differentiate them according to the staining characteristics of these WBCs. That's why these are known as the differential leukocyte count, DLC. Then there are few hematological indices like MCV, mean corpuscular volume, mean corpuscular hemoglobin, then mean corpuscular hemoglobin concentration, and the color index. These are the 4 indices we can calculate, not measure. We can calculate by using the different parameters like hemoglobin concentration, total erythrocyte count. By calculating these values, RBC values and the hemoglobin values, we can directly jump over the hematological indices. Then blood group determination. In early session, Dr. Neelan Jacob very well emphasized about the blood groupings in human beings as well as in the dogs and canines also. Then platelet count, then bleeding time and clotting time, and these all are the manual methods which we perform by our hand in our laboratory. And above this is the complete blood cell counter. This is three parameter or 4 parameter. This is 3 part and 5 part, and another 3 part and 5 part. They are also having the parameters. According to their parameters, we can say for example, one hematology analyzer is having the 3 part 18 parameter. Means it can analyze 18 parameters. It can show the result of the 18 hematological parameters at a time. But 3 part indicates it can show the results of only the 3 WBCs. Out of the 5 WBCs, it can show the results of the 3 WBCs. Likewise, 3 part 24 parameter. It can show the results of the 3 WBCs. But it can show the 24 hematological parameters at a time. Likewise, 5 part, it can show the results of the values of all the 5 WBCs. So number 1 is the hemoglobin concentration. So this is the hemoglobin is very important. We know very well that hemoglobin is present in the red blood cells, red blood corpuscles inside the RBCs. If the dry weight of the RBC, it covers approximately 95%, while in wet weight it is 30 to 34%. And one thing, this hemoglobin is present in the web-like structure in the RBCs, not in the concentrated form, and it is having the significance in our body. So, due to the web-like structure of the hemoglobin inside the RBCs, it can maintain the osmotic concentration of our body. If it remains in a ball-like structure, in a concentrated way, in any part of the RBC, then to combat the raised osmotic concentration, we need 10 times of the water. So, say for example, if our weight is 70 kg at this time, and our hemoglobin will be in the concentrated stage, our weight to combat the normalcy of the hemoglobin or the body osmotic concentration, our body weight will be 10 times more, in 700 kg. So this is the importance of the hemoglobin, and this hemoglobin always iron present in the ferrous form, not in the ferric form. And this iron in ferrous form combines with the oxygen loosely and forms the oxyhemoglobin in the lungs alveolus. And whenever the blood carrying the oxyhemoglobin reaches the tissue level or the far distant locating cells, it dissociates due to the higher concentration of the carbon dioxide or the decreased pH or the high temperature. In these conditions, this loosely bound oxyhemoglobin will dissociate and oxygen will use by the cells for their metabolic purposes, and the loose dissociated hemoglobin again binds with the carbon dioxide. So in this way, this hemoglobin is used particularly for the oxygen transportation. So when we talk about the principle of the hemoglobin estimation, so the substances we are using in this estimation of the hemoglobin, these are the number 1 N by 10 HCl. Number 1 is N by 10 HCl. The second one is the hemoglobinometer. This is also known as Sally's hemoglobinometer by the name of the inventor. Sally is the inventor of the Sally's hemoglobin estimation test. That's why this is the Sally's hemoglobinometer. This tube is known as the hemoglobin tube or Sally's tube. And this one is the pipette, Sally's pipette. And why how can we distinguish this pipette from the rest of the other pipettes? That's because it is having the 20 microliter marking in between. At the mid of the pipette, it is having the 20 microliter of the marking. So the principle is whenever the dilute acid, that is the N/10 hydrochloric acid, combines with the blood, it forms the acid emitter. There is destruction or hemolysis of the RBC, then the hemoglobin comes out, and this hemoglobin binds with the hydrochloric acid and forms the acid hemotin. This acid hemotin is the brown color or dark tan color. Due to the formation of the acid hemotin, this color developed within the 10 to 15 minutes, and after that, when we add drop by drop the water, distilled water, and then compare this acid hemotin mixed with the N/10 HCl or the water, distilled water, we compare with the colored columns which are located on both the sides of the hemoglobinometer or comparator box. Then we compare the color of the hemoglobinometric pipette tube with the brown color. So this is the basic principle. The values of the hemoglobin we can measure in this is gram per 100 ml or gram per DL or gram per sec. So the procedure means in hemoglobin pipette, in hemoglobin tube, first there are marking in the yellow, yellow marking where up to the 2 marking below. At the base point, there is the 2 marking in yellow color. At this level, we fill the 0.1 N HCl. And after filling this, take the blood sample, then mix properly, homogenize it, and then after inserting the hemoglobin pipette and suck the blood up to 20 microliter of 0.02 ml. 20 microliter blood after sucking, then wipe out the tip of the this pipette with the help of the cotton or swab. So the excess amount of the blood will not enter into the N/10 HCl containing hemoglobin tube. Then pour the blood, 20 microliter blood into the tube, and after that you can see the miracle. You see the change. There is gradual change in the color of the blood from red to the dark tan or brown color. This is the condition where this is the situation where the hemoglobin converts into the acid hemotin by combining with the acid. So then wait for the 10 to 15 minutes. In this period, whole of the blood hemoglobin convert into the acid hemotin. Then after, by adding the drop by drop this distilled water, and then again compare with the comparator box, brown column of the comparator box. So this is the first video. Here, this is the distilled water. This is the comparator box or hemoglobinometer. Then this is the yellow marking where up to the 2 marking. This is the 2 marking where we fill the N/10 HCl. This is the N/10 HCl. We fill here. So this is the yellow marking. It is 2, up to 2. This is the comparator box, hemoglobinometric box. Here after that, this is the hemoglobin pipette, and this is the 20 microliter marking, 0.02 ml. So this is the hemoglobin pipette. Then this is the collection of the blood up to the 20 microliter, and this is how we pour the blood into the hemoglobin tube. And this is you can clearly see that there is a change in the color. There is a change in the color in between the 10 to 15 minutes. And after 10 to 15 minutes, this is the dark tan color. We add drop by drop distilled water to match the color with the brown color columns of the comparator. This is the stirrer we are using to properly homogenize or mix the acetimetin with the distilled water. And after inserting this hemoglobin tube, this is how we are matching the color with the brown columns of the comparator. We need more distilled water. So you can see clearly that there is a gradual change in the color from dark tan to the brown, and still this acetimetin needs more amount of the distilled water to match the brown columns. So we need to take the precautions that abruptly we need not to add the water according to the need of the color of the acetimetin. We see this is the diluted acetimetin. So here we are adding the distilled water drop by drop. You can see at the base of this hemoglobin meter, this is how we add the drop by drop distilled water. Now you can see that still it needs more distilled water to reach the color of the comparator columns. So still it needs the now this is the color. You can easily compare that all the two columns and one tube having the same color. So after that we have to measure the value of the hemoglobin. So this is thus half moon shape of the liquid. So this is the base of the liquid where we have to measure this is approximately 13. So the value is the 13, and this is the 13 gram percent is the result of this hemoglobin. So these are the normal range of the hemoglobin in the different species. So next is the PET cell volume, PCV, or we can say the hematocrit. We can measure the PCV or the PET cell volume or the hematocrit by using two methods. One, when we have the ample amount of the blood sample, we can use the Winthrop tube. These are the Winthrop tubes. This is the picture of the Winthrop tube, and this Winthrop tube is having the size of 110 mm and 3 mm bore size. Its length is 110 mm and its bore size is 3 mm. So if we have more amount of the blood, we use this Winthrop tube method for the estimation of the hemoglobin, for estimation of hematocrit or packed cell volume. If we have less amount of the blood, we have an alternate, that is the microhematocrit method, where we use the capillaries. We use the capillaries and the microhematocrit centrifuge machine. For Winthrop tube, we use the simple laboratory centrifuge machines, while in case of the capillaries, when we use the microcapillaries, then we use this microhematocrit machine for the centrifugation. So, principle is, when the whole blood filled in narrow long tube is centrifuged, the heavier cells, definitely there will be the there are 3 columns formed after the centrifugation. The upper layer, which is the liquid portion, that is the plasma. The lower layer, which is occupying the heavy cells, that is the RBCs. And the middle layer is the buffy coat layer, which is single cell layer, buffy coat layer, which is having the WBCs and platelets. So these are the requirements for the estimation of the PCV. So here, for the Winthrop tube method, we have this Winthrop tube. It is having the graduations of markings from 0 to 100, from the base to the upper portion, and 100 to 0 from the upper portion to the base. And one thing, this Winthrop tube is equally used in the ESR estimation as well as the PCV estimation. This Winthrop tube is used in both the hematological parameters, ESR as well as the PCV. So after filling the blood into the Winthrop tube, we centrifuge it for 3000 RPM evolution per minute for 30 minutes. After 30 minutes, when we take out the centrifuge tube from the centrifuge machine, there will be 3 columns. These are the 3 columns. This is the upper portion, this is having the plasma, and this plasma is having all the components. Then this is the middle layer, this is the buffy coat layer, and this one is the red blood cell layer. This is the lower layer. And this is our interest, subject of interest. This is the PCV, packed cell volume. So what we perform here, we pour the Winthrop tube with the blood sample, then perform the centrifugation after 30 minutes for 3000 RPM. When we pull out these Winthrop tube, there will be 3 columns, and these 3 columns are like that. And this is the PCV. So these are the values of the different animal species. So this is about the Winthrop tube method. And second method is the microhematocrit method, where we are using the capillaries. By using these capillaries, we fill the blood into the capillaries, then block both of the ends with the help of the wax. Blocks of the wax, we blocks the capillaries, then we run the microcentrifuge at the rate of 8000 RPM for 8 minutes. Some laboratory persons use the 15,000 RPM for 5 minutes. So this is my standardization. We are using 8000 RPM for 8 minutes, and after that we are having this microhematocrit reader, where we place the this microcapillary, and we can perform the reading of the PCV. So after that, third one is the erythrocyte sedimentation rate. As I already mentioned that erythrocyte sedimentation rate we can perform by two methods. One is the Westergen method, another is the Winthrop tube method. This Westergen tube, it is having the size of 300 mm, and it is having the marking from 0 to 290, up to 0 to 290. So this is the Winthrop, this is the Westergen tube, and it is having the opening on both of the ends. And this stand is known as the Westergen stand. So definitely we have to fill the blood up to the 0 mark, up to the top of the Westergen tube. After filling this blood up to the 0 mark, we have to place the Westergen tube over this Westergen stand and keep it for 1 hour. And after 1 hour, how much of the erythrocytes will sediment, then we have to read the values like initial reading minus the final reading. In this way, we can calculate the ESR, and the value of the ESR will be in the mm. So this is the video. So this is the Westergen. Here we are going to compare the Westergen as well as the Winthrop tube methods. So this is the Westergen tube. This is 300 mm in length, and it is having the marking of 0 to 290. And this is how we have to fill the blood up to the upper 0 level mark. And after that, we have to wipe out the excess amount of the blood which is spilled over the glass tube. Then place it in the cushion, rubber cushion of the, with the help of the proper care. We place it on the Westergen stand. This is the Winthrop tube stand. This is the Winthrop tube stand. These are the Winthrop tubes, and they are having 110 mm of the length and 3 mm of the bore size. So this is how the plasma will be the superficial portion. This is the level. Final initial reading were here, and this is the final reading. So answer will be the final initial reading minus the final reading. Here, this is because it is having the deviations of markings from 0 to 100, sorry, 0 to 290 and 200 to 0. So we can easily calculate the ESR. So these are the values of the erythrocyte sedimentation rate. And my dear friends, this ESR is very well used in the prognosis of any disease, not in the diagnostic purpose. Like rheumatism and tuberculosis, it adds a clue. So in case of the cattle, it is 2.4. This is the 2.4 mm. And it is up to the 7 hours. And when you calculate it for 1 hour, it is 0 to 1 reading approximately. Horses in 10 to 20 minutes, it is 15 to 38, and 2 to 12 in the 10 minutes. In case of dogs, this is 6 to 10 mm per hour. Likewise, these are the values of the ESR from the different species. Now, TEC, total erythrocyte count. In TEC, total erythrocyte count. In TLC, total leukocyte count. In the platelet count, or any of the cell count. This is the hemocyte which plays a vital role in the counting of different kinds of the cells. So in case of our topic of concern, we are using this hemocytometer in 3 practicals. Number 1 is the TEC count, means total erythrocyte count. Second is the total leukocyte count, and third one is the platelet count. So these are the squares, as already described by earlier speaker, sir. These are the squares. These are the 9 squares. 1, 2, 3, 4, 5, 6, 7, 8, 9. So our concern, our main interest is these are the 4 peripheral squares which are made for the WBCs. These are the 16. In one peripheral square, it is having the 16 small squares, likewise 16, upper left, upper right, lower left. These are the 16 multiplied by 4, total 64 cells. So we have to count the WBCs in total for 64 peripheral small squares. Likewise, for the RBCs, these are the 25 central squares. And each 25 central square is further subdivided into 16 smallest squares. So 25 again divided into 16 smallest squares, and we have to count the RBCs in 4 peripheral. Likewise, same we count in the WBCs. Like this is the first we mentioned here is this is the left central square. This is the left central. This is the upper left central, upper left right central. This is the lower right central, lower left central, and this is the central square. So these are the squares where we have to count the cells up to 80 cells, 80 squares we have to count the RBCs. So these are the requirements, like this is the hemocytometer, NUBUS, counting chamber or hemocytometer. Then this is the WBC pipette and the RBC pipette. There are few differences between the WBC pipette and the RBC pipette. What are the differences? Number one, we have to keep in mind that these graduations, these markings are arbitrary only, arbitrary. They are not having any value. Say for example, we cannot say this is the 1 means 1 ml. This is not 1 ml. This is the 1 mark. This is the standardized. So we have the marking in both the WBC as well as the RBC diluting pipette up to this is the stamp. This portion is stamp. Another, this is the bulb, and this is the above the stamp. This is portion, and this is the rubber tubing, and this is mouthpiece. So again, I repeat, this is the RBC diluting pipette, which is having the stamp portion. This stamp is having the 2 markings. At the middle of the stamp, it is the 0.5 mark, and above, below the bulb, it is having 1 mark. And this is the marking or stamp size is same in the WBC diluting pipette also. That is 0.5 mark and 1 mark. Then there is a difference between the WBC diluting pipette and the RBC diluting pipette is the size of the blood. As far as the matter of concern of the WBC diluting pipette, the bulb size of the RBC diluting pipette is greater in size in comparison to the WBC. Right? It is having greater in size. Then above the bulb, another marking is the 101 marking. And this next important one is and it is having the red bead inside the bulb. Then what is the use of this bead here? What is the use of this bead? The main use of the bead is after dilution of the blood with the diluting fluid. Like in case of the erythrocyte count, we are using the RBC diluting fluid. When we fill the fluid in the bulb with the 0.5 mark blood, with the diluting fluid. After 5 to 10 minutes, this blood, this RBC diluting fluid will loosen the or will fragile the RBCs, and these fragile RBCs, whenever they comes in contact with the bead, so by the physical action, when we rotate or slightly rotate this pipette, this bead destructs the fragile RBCs, and through this destruction, the whole of the hemoglobin, whole of the rest of the cells, except the RBCs, the rest of the cells except the RBCs will lose its integrity and they will destruct. But the main function of the diluting fluid is they keep the consistency, size, shape, color of the RBCs and destruct rest of the RBC cells like WBCs and any other cells of platelets. So these are the requirements: hemocytometer, microscope, RBC diluting fluid, and blood sample. When we talk about the procedure, so we have to fill the blood up to 5 mark. Up to 5 mark, we have to fill the blood. After filling the blood, excess amount of blood which stick over the RBC diluting pipette, which we have to wipe out by using the wet filter paper or the filter paper by using the filter paper. After sucking the blood up to the 5 mark, then take a watch glass and pour the RBC diluting fluid on the watch glass. There are different kinds of the RBC diluting fluids, Haynes fluid, and then physiological saline fluids, and there are different RBC diluting fluids available in the market. So these RBC diluting fluids, their main function is to maintain the integrity, shape, size, and the consistency of the RBCs, and simultaneously they destroy the other cells. Then we have to fill the RBC diluting fluid up to 101 mark. Up to 101 mark. So here, what is the importance of this 101? So we fill the blood up to 0.5 mark. Then we dilute the RBC diluting fluid up to 101 mark. So this blood up to 5 mark, after up to 5 mark, when we suck the RBC diluting fluid, as the RBC diluting fluid enters into the stem of the RBC diluting pipette, this blood will slowly comes into the bulb. And after sucking 1 mark of the RBC diluting fluid, the whole of the 0.5 mark of the blood will be in the bulb only. Now it is not in the stem. So after filling up to the 101 mark of the diluting fluid, this 1 mark up to the 1 mark of the diluting fluid is our not use. We cannot use this 1 mark because this 1 mark of the diluting fluid is not diluting the blood. Where it is diluted? It is diluted into the bulb. So after dilution with the RBC diluting fluid, we keep the RBC diluting fluid for 5 to 10 minutes for the further reaction to take place. And after 5 to 10 minutes, we take this RBC diluting pipette and hold it in between both the palms, and slowly we have to rotate to homogenize the RBC diluting pipette containing blood in the bulb. So after 1 minute of this rotation, the whole of the solution inside the bulb will be homogenized. So after that, we have to discard. Meanwhile, we have to prepare the hemocytometer under the microscope. First, we have to set the microscope under the low power microscope. Under the low power microscope, that is the 10x, we will see the all of the 9 squares, all the WBC squares, including the RBC squares. Then set it over the 40 or 45 x of the power of the microscope, that is the high power of the objective lens. Here we can only view, we can at the 40x of high power of the objective lens, we can only view these 25 squares only. Then we jump over to the 40x. So at this 40x, we will observe at a time, we can observe only one central square. It may be left central, upper central, it may be left lower central or lower right central or any of this. So at the 40x of the microscope, we can zoom at particular central squares, only one central square, which is having 16 smallest squares. So after that, discard 2 to 3 drops. It indicates that all of the 1 mark, this diluting fluid will be wiped out. And after that, place hemocytometer, this slide, particularly meant for the hemocytometer. So this slide is having the depth of 1/10 mm. So there is a gap between the platform of the hemocytometer and this cover slip. This is 0.1 mm gap, and through this 1.1 mm gap, the whole of the RBC diluting fluid containing RBCs will be entered in the square, and this is having the one layer. This is having the single layer, and keep it for some time to settle down the RBCs. Then observe the RBCs and count all of the RBCs under the 40x of the microscope. So here the dilution factor is 200. Here, in case of the RBC diluting fluid, the dilution factor is 200 because we have the 0.5 mark blood. 0.5 mark blood, we are having the 101 mark of the RBC diluting fluid. But this 1 mark blood is no use for us. That's why total 0.5 mark of the blood is diluted in the bulk with the 100 mark of the RBC diluting fluid. That's why if 0.5 diluted with the 100, then 1 mark diluted with the 200. That's why the dilution factor is 200. So this is how we can prepare the TEC. So this is the hemocytometer, this is the RBC diluting fluid, this is the composition of RBC diluting fluid, that is the hemes diluting fluid. This is hemocytometer, this one is the RBC diluting pipette, and this is the WBC diluting pipette. So this is how up to the 0.5 mark the blood is sucked. After 0.5 mark, the diluting fluid is filled up to the 101 mark, and after mixing, this is the mixing method by rotation. So this mixing is, why this mixing is important? This you can show that, you can see that this is the excess amount of the diluting fluid, which is sucked out. This is the hemocytometer, how this blood, RBC diluting fluid containing the blood is entered inside in between the hemocytometer and the cover slip. This is the layer. This is the layer, and this is how we can prepare the single layer of the RBC diluting fluid containing RBCs. So this is under These are the red area indicates the RBC squares. These are the 5 squares, and this is the structure of the RBCs, which we can observe under the high power of the microscope. This is the 40x of the objective lens. So for the counting of the RBCs under the microscope, we are using the 40x of the objective lens. So these are the RBCs we have to count. And there is a particular rule for the counting of the RBCs. So this is the how we can count the cells. Like this is the square. This is the square, small square, which is again further subdivided into 4 by 4, 16 smallest squares. So when we take the example of one square, one smallest square, it is having 4 sides. This is the upper side, this is lower side, this is the left side, and this is the right side. So when the cell is located on the upper border, so this upper border cells and the left side of the border cells are always considered in the same square. We have to count in the same square. Upper and left border cells, located cells are always counted in the same square. But why? Then the lower border cells are considered in the below square. It will be counted in the below square, while the right side of the border, it will be counted in the next square. So this is the corner square. This is the middle square. When we talk about the upper square, this is the upper square. So upper square here, in case of this one is the 6th square, small square, 1, 2, 3, 4, 5, 6. When we may consider the 6th smallest square, so this is the upper border of the 6th smallest square, but it is simultaneously considered as the lower border of the 2nd smallest square. So when we are counting the cells in the 2nd square, this lower border cell, it will not consider in the 2nd, but it considered in the 6th square. So this is the counting rule of the WBCs or RBCs or any of the cells which we are counting. So these are the different values of the animals of the TEC. Now the TLC, the whole procedure is same, but there is change in some points, like number 1, the marking are same in the stem, 0.5 and 0.5 and 1. This is same, but there is a difference, that is the bulb size is smaller in comparison to the RBC square, RBC diluting fluid bulb. And above the bulb, this stem is having the 11 marking. Instead of this WBC diluting pipette, the RBC diluting pipette is having the 101 marking. So the dilution factor definitely we consider the 10 mark. So the dilution factor is 20. While in case of the RBC diluting pipette, the dilution factor is 200. Another important significance is whether this bulb is having the white bead or the transparent bead. Okay, maybe it is having the white bead. This is white bead, or maybe it is having the transparent bead, but not the red bead. So this is the important characteristic feature. Number 1 is the size of the bulb. It is smaller in case of the WBC diluting pipette, greater in case of the RBC diluting pipette. Then bead is red color in case of the RBC diluting pipette, while it is white or transparent in case of the WBC diluting pipette. Third one is the marking above the bulb. It is having 11 marking in case of WBC diluting pipette. We always consider our WBC diluting pipette, not WBC pipette, because to dilute the blood samples. That's why it is WBC diluting pipette and RBC diluting pipette. So these are the WBC areas. Only difference is again in procedure. This is the WBC diluting fluid. Commonly used WBC diluting fluid is the Turk's fluid. TURK apostrophe S, Turk's fluid. So here these are the WBCs which we have to count, and these WBCs here again this procedure 0.5 mark. We have to suck the blood, then wipe out the excess amount of the blood, then up to the 11 mark we have to fill that WBC diluting pipette with the Turk's fluid or WBC diluting fluid. After 5 to 10 minutes, again this 5 to 10 minutes are needed to sensitize the cells. In case of the RBC diluting, in case of the RBC diluting fluid destroy or get fragile the cells other than the RBC. In case of the WBC diluting, it maintains the shape, size, and consistency of the WBCs, and meanwhile it get fragile the other cells. So after 10 to 15 minutes, again roll this pipette slowly and slowly to homogenize and to destruct the cells other than the WBCs. After that, again 1 mark fluid we have to discard. After that, again fill the WBC diluting pipette containing blood, homogeneous blood solution into the hemocytometer. Meanwhile, set the microscope up to the low power of the microscope, that is the 10x. So WBC counting always we are performing in the 10x of the objective lens, while the RBC counting is performed under the 40x of the microscope, right? So this is again how we are filling WBC pipette. This is the 0.5 mark, this is the 1 mark, first mark, second mark, and third mark is the 11 mark. So this is the bulb. Bulb contains a white glass bead. It acts as stirrer to mix. So this is where this is the way we have to. This is the way we have to suck the blood up to. This is the 0.5 mark, right? This is the 0.5 mark. 0.5 mark blood collection. Then this is the Turk's fluid, which we have to fill up to 11 mark. This is the composition of the Turk's diluting fluid. See, the up to 0.5 mark blood is now entering into the bulb, and after that, this is the 1 mark, only the Turk's fluid. There is no cells. So, my dear students, if we fill the hemocytometer from the initial portion of the fluid, we will not observe a single cell. So this is the hemocytometer. These are the 2 modes or the 2 platforms where we have to perform, and at a time 1 platform is used. This is the special cover slip. Put it over the glass slide, and this is the capillary space where we have to put the pipette, opening of the pipette. So this is the rolling of the pipette. This is the cover slip. And how we discard the, this is the only the turf fluid. Here in this stamp, there is no WBC, RBC or any blood particle. So if we perform our hemocytometry by taking this turf fluid, we will have the pseudo results. So this is for the settlement of the, this is known as a charging of the hemocytometer. This is the low power microscope. Now this is under 10x microscope. We can see in the all the 9 in 4x. In 4x we can see the all the 9 squares. When we jump over to the 10x of the low power of the objective lens, we can only see these 16 small squares at a time under 10x of the objective lens. You can see the, so this is the counting of the cells. Again, this is the right upper side counting, right lower side counting. Then this is the left lower side counting. After counting, this is the n number of cells we observe. These are the WBCs. Here we cannot see the nucleus of the WBCs. Okay, so this is how we are counting the cells. Here the volume is always 1/10, means. So these are the counted particles, means n number of the cells. We count under the 16 multiplied by 4 means 64 small squares. The number of cells counted in 64 squares. We put this value over here. Then the dilution factor divided by dilution factor. Dilution factor is 1/200. Then these are the 64 squares. We have to calculate the volume. For the calculation of the value, we have to first calculate the area, then the volume. When we multiply the area with the volume, that is the 1/10 mm, we can depth, we can have the value of volume. So this is the area counted, definitely 1 mm square. This is the area of 1 mm square. Into 4, 1, 2, 3, 4. These are the, this square is 1 mm by 1 mm. So length multiplied by breadth is equal to 1/1 is equal to 1 mm square. So these are the 4 squares, 1, 2, 3, 4. That's why you have to multiply the 1 mm square multiplied by 4 is equal to 4 mm square. So these are the area of 4 large corner squares. This is the number of cells we counted on the whole of the 64 peripheral squares. This is the depth of the counting chamber. This is 1/10 mm or 0.1 mm. Dilution factor is 1/20. So now this is n number, and n number divided by area and multiplied by dilution factor. So the area, it is the 1/4 mm square for the 64 squares. Then dilution factor is 20. When we calculate this factor, our factor will be the 50. So n multiplied by 50, and our answer will be, for this hypothetical result, the answer will be 3,950 WBCs per cubic mm. Either we say that per cubic mm or WBCs per mm cube. So this is how we can calculate the WBCs. These are the values of the WBCs. Like in horses, it is 8 to 11,000 per cubic mm. Cattle 7 to 10,000. Goat 8 to 12,000. While in case of the chickens, it is 20 to 30,000 per cubic mm. Dogs, its value is 9 to 13,000. Now, differential leukocyte count, DLC. So, we are observing the TSE, or we performing the TSE under the 40x of the objective lens, while WBC or TLC under the 10x of the objective lens, and this DLC, differential leukocyte count, we perform under the 100x of the microscope, or we can say the other name of the 100x of the microscope is the oil immersion objective lens. Oil immersion, because we are using here the oil to reduce the refractive index. Reduce the refractive index. Okay. So procedure, it is the procedure already. This is how we prepare the slide or smear. Typical tongue shape of the smear. We observe, keep it to dry. Then after that, fix it. Then after the proper staining, always keep in mind whenever we use this microscope, so it must be a routine. It must be a routine that first we set the microscope or any of the slide under the low power of the objective lens, always. And after that, you slowly and gradually, you can proceed at its normal objective lenses. So this is the table where we can count the cells. Like we have to figure out these WBCs, then total counting we can count by the square method or the bar method, or we can prepare this checkerboard method, which is having the 100 squares, and whatever the cell we observe, we just mention over the table. And another, this is the cell counter, which is having all the base of eosinophils, monocyte, lymphocyte, polymorph, means these are the neutrophils, eosinophils, and this is the neutrophil. So whenever you observe any kind of the cells, you have to press the button related to the particular WBC. And this is how, when the total counting will be 100, we stop the counting, and this will be our result, which is considered in the percentage. So how we can view the different cells. So these are the different cells. Like this is the monocyte, which is having hose shoe shape nucleus. This is the eosinophil. These are the neutrophils. These are the different neutrophils. This slide we are observing under the 100 power of the microscope. So its size is 10 to 12 micron in diameter and 2 to 5 nuclear lobes. It does not mean that they are always having the 5 lobes. It may be 2, 3 or 5 we can have. So they are having the granules, and their granules are fine powdery. Their granules are fine powdery and bluish or purplish color. There is a difference between the basophil and the neutrophil, that both are having the purple or blue color of the granules. But in case of neutrophils, they are having the powder form of the granules, while in case of the basophil, they are having coarse granules. COARS, coarse granules. So this is the example. This is the picture of the eosinophil, and it is having 2 to 3 lobes, and its shape is characteristic shape is spectacle shape. Gandhiji ka chashma. So this is the spectacle shape of the nucleus we are observing, and the granules are red or orange in color, and particularly they are having the great number in the allergic condition as well as in the parasitic infestation. This is the basophil. Normally it is less common, and its range is 0 to 1 or normally 0 to 1. So it is having 8 to 10 micron in size. So stimulate inflammation during allergy condition. Next is the agranulocyte. First agranulocyte is the lymphocyte. And this lymphocyte, this number may vary from the species to the species. They are, according to the size, they are small as well as the large lymphocyte. And according to the immunity, it is B lymphocyte, which provides the humoral immunity, and another is the T lymphocyte, which provides the cellular immunity. So these are, and another difference in the small and the large lymphocyte is, so this is the monocyte, which is an indented or horseshoe shape, C-shaped shape. You can also consider C-shape or horseshoe shape of the nucleus. But they divide the granules. So the lymphocytes and the lymphocytes as well as the monocytes, they divide the granules. So this is the range of the different leukocytes present in the different animals, like the cattle, buffalo, goat. These cattle, buffalo, sheep. These three animals are having the neutrophils only 25 to 30, eosinophil 2 to 5, basophil 0 to 1, and lymphocytes are in greater number 60 to 65. Monocytes are this. While those same as like the humans, they are having the neutrophils 50 to 60. And dogs, they are also having the numbers of the neutrophils predominantly greater in comparison to the lymphocytes. So these are the hematological indices, like mean corpuscular volume. This indicates the volume of the RBC, single RBC, volume of single RBC. Okay, so this is we calculate in the cubic micron, and this MCV we can calculate through the hematocrit percentage divided by TEC, hemoglobin divided by TEC multiplied by 10. The mean corpuscular hemoglobin concentration in 1 RBC. It is the MCHC. So hemoglobin gram percent divided by TEC multiplied by 10. So this is in the micro, or we can say the picogram. The mean corpuscular hemoglobin concentration. So this is the index which indicates the degree of saturation of hemoglobin in the red cell. So this is how we can calculate, like MCH divided by MCV multiplied by 100, or in another way, the hemoglobin concentration multiplied by TEC divided by, this is the erythrocyte per cubic mm multiplied by hematocrit multiplied by 100. So these are the hematological values, and these are the different MCV, MCH, and MCHC values in the different animals. Now blood grouping. So the blood grouping, it is there are 3 types: ABO system, MRNP, RS system, and these are the requirements. We need the 3 anti-sera A, B, and anti-RS factor, and we can use the blood grouping slide also, or we can use the normal slide for performing these results. So these are the tabular of the different blood groups which are identified here in different animals. So this is the slide technique where these are the sorry. So this is how and this blood grouping is already covered in our previous session, but again this is the repetition for a better understanding. So this is the slide, and this is how the blood is collected. In our veterinary practice, we are not using this method for the collection of the blood. So this is how we prepare the drop of the blood over the slide. These are the 3 drops of the blood on one slide. Then on first drop, we add, this is the NTD, this is NTB, and first one, this is the NTA. Now we have to mix. We have to mix both the drops gently. So this blue color indicates the anti-serum A, yellow indicates the anti-serum B, and this white indicates the anti-D factor. Whenever there is agglutination occurs, the granules we observe, it indicates that the particular person is having the particular type of the blood group. So this is the agglutination. This is agglutination. The platelets are having the properties of the character feature of adhesiveness, clotting, as well as the agglutination. So this is the O negative. This is AB positive. In this, this is the AB positive, where all the 3 slides are having the agglutination A, B, and O. It indicates this is the this AB and this AB blood group. It is having both the antigens. It is having the A antigen as well as the AB antigen, and both the antigens are always located on the surface of the RBCs, while the anti-serum, it is produced or formed in the serum. So this is the AB positive, then this is the AB negative, this is A negative, this is A positive. This is the sign of the different blood groups. Now platelet count. So platelet count, this is the counting, and mainly the bacterial infection like malaria. There are different conditions where the platelets count decreased sharply. So the procedure is same. We are using the hemocytometer. We are using the RBC diluting pipette. Again, blood will be filled up to the 0.5 mark, and up to 101 mark, we have to fill the blood. We have to fill the platelet diluting fluid, rich and aqueous fluid, according to the inventor of the scientist. This fluid is used, and for 5, we put it this RBC diluting pipette containing the solution into the Petri dish having the wet filter paper. So this Petri dish, we require the moist filter paper for the settlement of the settlement of the platelets. So this is again the dilution factor is 200, volume simple. This is the 0.1 mm. In platelet per cubic counting, this is the number of platelet, that is the N, and multiplied by 200 divided by 0.1. So this is the calculation, number of platelets multiplied by 200. We observe this under the 40x of the microscope. This is how we have to place the hemocytometer. Place the hemocytometer in the covered Petri dish, which is having the moist filter paper. So this is how first we have to set on the 10x, then jump over to the 40x and lower the condenser and let it decrease by adjusting the iris diaphragm. Here we need the less light. So these are the RBCs and this is the WB. This is the platelet. They are in the star shape. Star shape platelets are observed. So this is the counting method for 1 in 20 dilution. So this is the larger center they are using for the counting of the RBCs. So these are the central squares we are using for the counting of the RBCs as well as for the WBC, for the platelet cells. So platelets here, they are definitely located in whole of the central square. So this is the platelet. So this is how we calculate the platelets and multiply by dilution factor. Dilution factor is 1:200, and here the volume of the fluid. This is of course 1/10. So next is the bleeding time and clotting time. So bleeding time, definitely when that whenever there is rupture of the blood vessels, then the blood is oozed out from the ruptured vessel, and the time passed between the moment of escape of the blood outside the vessel and time to cessation of its flow. So when the blood comes out from the blood vessels and stoppage of the blood from the blood vessels, the time in between is known as the bleeding time. And normally it elongates during the purpura condition. So this is the deep method we are using for the bleeding time. Again, this is the filter paper. The capillaries we are using in the clotting time. So the blood is pricked from the fingers here. This is a stopwatch, and after every 30 seconds, we have to make an impression over the filter paper. So we start the stopwatch after clicking the finger. Now this is after 30 seconds, we make impression of, this is impression of first, and every 30 seconds we are making the impression, And after that, ultimately, when the blood stops oozing from the cut blood vessel, we stop the timer and we count the bleeding time. Say, for example, this is a 0, 30, this one 0, this one is the 30, 60 is 1 minute, 1.5, 2, and 2.5 minutes. So this is our counting. So normal bleeding time is 3 to 5 minutes. Next is the clotting time, definitely. So after oozing out from the cut blood vessels, the formation of clot, the time between the oozing out of the blood from the blood vessels to the formation of the clot. This is known as the clotting time or coagulation time. It prolongs in case of the hemophilia condition. Again, in place of the filter paper, we are using here the capillaries. We have to fill the capillary with the blood. So after pricking, this is how we have to fill the blood in the capillary. In case of PCV microhematocrit method, we have to fill the blood in this manner into the capillaries. Now we have to note the time after 0 time, and after every 30 seconds, we have to break the capillaries. If there is a formation of thread in between the two divided ends of the capillaries, this is the clot. Thread, this is the clot, and these are the pieces of the broken capillaries, and each piece indicates the 30 seconds. So 1, 2, 3, 4, 5, 6. So this is approximately 3 minutes. So after that, the manual methods. Now this is the automated hematology analyzer. This ease our function and save our time. For performing all these hematological parameters by the manual method, we take the time more than 1 to 2 hours time for a single sample to perform all the hematological parameters. But in case of these hematology analyzer, we need only fraction of minutes to complete the exercise. So this is the very ready to use automated hematology analyzers, and these are 3-part or 5-part or same like parameters. It may be having the 18 parameters or 24 parameters, right? So these are the three parts according to the blood WBCs, and these are the other parameters like include RBC distribution. This is now width. This is RDW, MCV. So in this, these are the RBCs, TEC, TLC, hemoglobin, platelet, and PCV. This is the PCV. While these are the determined values like calculated values, RDW, RBC distribution width, then MCV, MCH, MCSC, WBC differential count in percentage, and absolute value, platelet distribution width, PDW. These are the. So what is the principle? It's principle that particles pulled through an orifice, a minute orifice. The particles have to pulled up through the minute orifice. These are the glass channels, and concurrent with an electric current, and produce a change in impedance that is proportional to the volume of the particle traversing the orifice. This pulse's impedance originates from the displacement of electrolyte and caused by the particles. Here we are using the diluent as well as the lysant. Two chemicals we are using here, and but the cost of the lysant and the diluent is very costly. Okay, but it definitely is our hematological analysis. So these are semi-automated and the fully automated cell counters, and according to these cells, these are the 3 parts like granulocytes. Granulocytes, it includes both it includes the neutrophils, basophils, and the eosinophils, all the 3 cells, the lymphocyte and monocyte, and 5 part, it includes all, it count all the WBCs in separate. With that, I conclude my and for that, I would like to thank the ICR and IDP and the university of our university, Junagadh Agricultural University, for providing me the platform to express my view in front of the professional community. So thank you very much.
Thank you, sir, for such an informative presentation. Now, the session is open for discussion.
Madam, your voice is not clear. I'm not getting.
Now, may I audible?
Okay.
Thank you, sir.
No, I'm not getting your voice.
Now, audible?
No. Wait a minute. I'm opening my Zoom meeting through the mobile. Please wait a minute.
Okay, sir, अब ठीक है?
आवाज आ रही है सर सर आप लोग वही सालों को सर
हेलो
क्या जो है
सर आपको आवाज नहीं आ रही है, अदरवाइज सिस्टम इज वर्किंग।
सर आपकी आवाज थोड़ी सी आ रही है, साहब आपकी आवाज थोड़ी आ रही है।
ओके, सो
मैं इसको मोबाइल से कनेक्ट कर रहा हूँ।
हाँ जी सर, because we have some queries from UG and
PG. Now technical session is open for discussion.
Hello. Yes, sir.
हाँ जी. Okay, so we have some queries from UG and PG student. First, please ask your query by PG student.
Good afternoon, sir. Myself, Dr. Vivek, PG scholar in Department of Livestock Production and Management under the guidance of Dr. G.P. Sabapra, sir. Sir, my query is that you mentioned about anticoagulant vials in your presentation. In context to that, sir, sometimes we are devoid of such vials in the field condition. So in that situation, how should we proceed the blood sample? And is there any traditional techniques for blood sampling and preservatives in the field condition?
I'm not getting your question. Please repeat.
Sir, my question is that you mentioned about anticoagulant vials in your presentation. In context to that, sir, sometimes we are devoid of such vials in field condition. So in that situation, how should we proceed the blood sample? And is there any traditional techniques for blood sampling and preservatives in field condition?
Please, one more time, please repeat.
Sir, he is asking regarding that. Okay. Sir, this question is regarding, is there any traditional methodology to preserve the blood in the field condition?
Traditional natural procedure to preserve the blood. Right?
Right.
Yes, sir. Yes.
To preserve the blood natural. We can preserve the blood by defibrillation method. One is defibrillation by using.
Sir, your sound is doubling. Hello, excuse me, sir. Your sound is doubling. Either you shut your sound of your PC. Only one sound you just open. Yeah. Otherwise, if you are talking with the phone, can you close the sound of your PC, sir? Echo is to produce. Echo is producing.
Through
use only one instrument.
I will start my mobile Zoom and I will.
Okay, now I think it is clear. Okay, sir. Hello.
Sorry, here's a problem. I think my
Sir,
voice is
clear. Your sound. Yes, exactly, sir. We are getting your clear voice.
But I can't hear your voice.
Ah. जी जाओ तो फटाफट.
Okay, now.
सर आपकी आवाज बिल्कुल क्लियर आ रही है.
Yes, please.
Is it okay now? Hello.
Hello.
Yes, we are getting your sound, sir.
Yes, sir. Yes, sir.
Yes. So, question is there is any traditional method to collect and preserve the blood for longer period for the analysis? Analysis of the blood in the field condition, sir.
It's a very good question. But I don't know. Please throw a light, Dr. Dodia. You throw a light.
Sir, sometimes some doctors and field veterinarians are used matchstick tip in field to preserve and anticoagulant, right?
Means people are using the matchstick.
Tip.
Okay, this is the method we are using. Yeah, this is the method we are using for the defibrillation of the blood. So it prevents the clotting. This prevents the clotting.
That's why if the sample right. So is
it is called defibrillation.
That is okay, sir. But can't we analyze? We can analyze some parameters from that sample. What about its reading? I'm not sure. Actually, I don't know. Actually, that matchstick contains the phosphorus. This phosphorus may, they preserve the act as the anticoagulant. Maybe I don't know how it works.
We can use the matchstick, or we can use the simple wooden stick also. It is not required that we use the matchstick. The only purpose is to avoid the sticking of the platelets over the wall of the test tube or any container from where we collect the blood. If we protect the blood from the surface, we can preserve the blood. We have to stop the clotting. We have to prolong the clotting. Okay. If the clotting time will be increased, the blood will be automatically preserved.
Okay, sir.
Got it?
Okay, next question, please.
Okay, okay, sir.
Hello, sir. Hello, sir. I am Pipalya Dishal from first year veterinary student. My question is, why does hemoglobin have a higher affinity for carbon monoxide in compared to oxygen?
Yes, repeat this question.
Why does hemoglobin have a higher affinity for carbon monoxide as compared to oxygen?
As compared to oxygen, it is having 200 times more. It is having 200 times more affinity than the oxygen, and carbon dioxide is having 20 times more affinity. Okay.
Because why, sir?
He is asking why. Why it is happening?
So actually, it is readily permeable to the RBC's membrane and stick to the enters into the RBC membrane readily in comparison to the oxygen as well as the carbon dioxide. So in our ancient time, as Dodia mentioned, we are using the sigdis for keeping us warm in the winter season. And when we close the whole of the room, and this sigdi means we are using the fire, means these dung of the cow dung, dried cow dung. Yeah, dried cow dung, and these liberate the huge amount of the carbon monoxide, and it is having the fruity smell. And without knowing any situation, we will keep inhaling these carbon monoxide, and this carbon monoxide, after entering in the blood, it will permanently damage the hemoglobin, and this hemoglobin containing the iron, which is totally useless for the another oxygen or any transportation of the means respiratory gases. So this carbon monoxide is very hazardous, and it is having the fruity smell, and it can penetrate and can enters into the membrane so easily in comparison to the rest of the other gases. That's why this carbon monoxide is very harmful.
Okay. Thank you.
Okay, we have another question from first year student.
Hello, sir. Sir, myself Deepak Saini from first year BSc and A.H course. Sir, my question is that, is there any advantage to birds of having nucleus in their RBC?
Is there any advantage?
Avian.
Of a nucleus present in the RBC of birds.
Avians.
Avians. Yeah. The mammals, particular mammals, are enucleated. Okay, they're lacking the nucleus from their RBCs. And what is the importance? Because the hemoglobin Hemoglobin occupies the major area of the RBCs in case of the mammals, and this hemoglobin, which present in the web-like structure, it provides the more transportation of the oxygen. More and more amount of the oxygen can be transported through the RBCs and the hemoglobin. Okay, and this AVs and the poultry are having the nucleus, and we can say that this nucleus, particularly the poultry is containing the nucleus, and it is having the significance. They are having the significance in case of the poultry, and the role of the nucleus here is, means there is less size of the poultry, and they need the less oxygen amount, less oxygen, in my view. Okay, the opinion may be different. Okay, so
Okay, sir. Thank you.
that's the story.
Okay, thank you, sir.
Okay.
Okay, thank you very much, sir. It was very fruitful and nicely presentation was given by you, and it contained lots of video. And some of the practicals we are also going to be conducting in our laboratory when physically our practical classes will be started for the first year. And sir, it was very nicely presented and very fruitfully videos particularly. I think my message to the students are, please remember that videos, because we have to going to repeat this all practicals in the coming days. So thank you very much, sir. And we are concluding today's day. And tomorrow we will have two lectures in the same time at the 9:30, and afternoon we will have a plenary session. For that's all for today. Thank you, everyone. Thank you.